الشيطان الرجيم.
अच्छा Bismillahirrahmanirrahim. Ladies and gentlemen, Assalamu alaikum and good morning to all of you. I'm Dr. Sabah Hassan Shamim. I'm an associate professor in Dow International Medical College and consultant histopathologist in Aga Khan, and I will be hosting this session. Once again, I take immense pleasure in welcoming all of you to the 43rd Annual Conference of the Pakistan Association of Pathologists and the 8th Conference of Societies of Pathology. Let's begin the 4th histopathology session on surgical pathology updates. To moderate this session, I would like to request Dr. Umayya Tahir, consultant histopathologist, Aga Khan University Hospital, to please come on stage.
Thank you, Dr. Sabah. Assalamu alaikum everyone and a very good Sunday morning. Before starting the session on updates, surgical pathology updates, I would like to invite chair and co-chair of the sessions on the stage, please. Please welcome chair of the session, Dr. Akhtar Sohail Chughtai from Chughtai Institute of Pathology, Lahore, and co-chair Professor Farzana Memon from Bilawal Medical College, Jamshoro. Moving forwards, this is just a humble request to all the honorable speakers that it would be highly appreciated if the talks are wrapped up within the allocated time slots. Starting our session, I'm pleased to invite our first speaker, a renowned histopathologist from Liaqat National Hospital and Medical College, Karachi. Please welcome Dr. Naveen Faridi.
Assalamu alaikum, everyone. Can I have my first slide? यहीं से करें, okay. Okay, I'm. ये तो पूरा आ ही नहीं रहा. कट क्यों रहा है? फुल आता है? हाँ. Okay. So my talk is going to be on the update of molecular pathology and shifting classifications of uterine and vulvar carcinomas. We all know that the molecular information is increasingly used for the typing of neoplasms, for the risk assessment and directing cancer treatment. So I'm going to be talking about the major developments that have taken place in 3 tumors, the endometrial carcinomas, endocervical adenocarcinomas, and vulvar squamous cell carcinomas. So let's start with endometrial carcinoma. Endometrial carcinoma is the most common gynecological malignancy in the developed world, and the increasing incidence annually and mortality rates are increasing every year. This is just a quick view of the overall incidence of endometrial carcinoma over the world, and even in Pakistan, the incidence is around 3 to 5 cases per 100,000 women. Endometrial carcinoma have been traditionally divided into 2 types, the type 1, which was endometrioid and was estrogen sensitive, and type 2, which was non-endometrioid, unrelated to estrogen, and included serous and clear cell carcinomas. Low-grade endometrioid carcinomas are reproducible. It's not difficult to diagnose them, and the reproducibility is easy. However, high-grade endometrioid carcinomas have considerable inter-observer variability and significant overlapping features in clinical, pathological, and molecular levels. Therefore, the Cancer Genome Atlas, TCGA, identified 4 groups of endometrioid carcinoma on the basis of prognosis. The first group was the pole mutation with pole mutations or pole mutant group, which has the excellent prognosis. Second group was with microsatellite instability, which had intermediate prognosis. Then the third one is low copy number, which was microsatellite stable, again an intermediate prognosis. And finally, the P53 mutant, which had poor prognosis. And if you look at this algorithm, the endometrial carcinoma is first tested for pole mutant. And if it is pole mutant, it is directly the pole mutant type of endometrial carcinoma. However, if the pole is wild type, then it should be tested for MMR genes. And if it's MMR deficient, it becomes MMR deficient endometrial cancer. And if it is MMR proficient, it should be further subtyped by doing a P53 marker. If it is P50 wild type, it is a non-specific molecular profile endometrial carcinoma, and if it is P53 mutant, it is a P53 mutant endometrial carcinoma. And this is how the 4 groups are diagnosed. And if you look at the overall incidence, the most common is the one which is MMR deficient, account for 40% of the cases, followed by the non-specific molecular profile types, 30%, and P53 mutant, 18%, and pole mutant, 12%. Look at the recurrence-free survival times. As you can very well appreciate that the pole mutant has the best 5-year survival time, followed by MMRD. Then the non-specific molecular profile types, and the worst prognosis is that of P53 mutant endometrial carcinoma. Diagnostic tools, the pole mutations are tested by next-generation sequencing. I agree that this is not very widely available, and it may be difficult to do that. However, the MMR gene and P53 is easily done on immunohistochemistry and should be now considered doing on all cases of endometrial carcinomas. And these are the morphological types of all the 4 different types: the pole mutant, MMR deficient, P53 wild type, and P53 mutant. Clinical features are definitely significant in these all 4 types. In the pole mutant one, they are seen in younger age group. The stage of the disease is early. It has excellent outcome, and this is highly responsive to immunotherapy. Even if the grade of the tumor is high, and if it is pole mutant, it has excellent prognosis. The MMR deficient ones are seen in middle-aged females, which high BMI, they are obese females, they have extensive lymphovascular and lymph node involvement, and these tumors are generally seen at the lower segment of the uterus, and with tumor-infiltrating lymphocytes, and again, they are highly responsive to immunotherapy. The P53 wild type, which is microsatellite stable, and copy number low, again is seen in middle-aged females. They are obese, they are estrogen, there's estrogen exposure, and there is the hormonal management is the treatment of choice. This really accounts for the old endometrioid or type 1 type of endometrial carcinoma that we used to classify previously. And these tumors are low grade, low stage, and again have a favorable outcome. P53 mutant is seen in post-menopausal females, which are not obese, usually have thin physique. The histology is serous or serous-like. There is lymphovascular invasion, extensive destructive growth pattern, and of course the poor outcome. So these account for the previously type 2 endometrial carcinomas. The 4 types of endometrial carcinoma, the pole mutated one has a highly responsive to immunotherapy and excellent prognosis. The MSI high one again has a high response to immunotherapy. The microsatellite stable, and the one which has no molecular profile has the same type of molecular markers like the type 1 endometrioid carcinoma. They have variants in P10 mutations, there are PIK3CA mutations, and so on and so forth. And the 4th group, which is copy number high, is P53 mutant in most of the cases and has a higher relapse rate and poor survivor. So take-home points for endometrial carcinoma. The molecular subtyping of endometrial carcinoma is going to become standard of care. TCGA classification is divided into 4 groups: the pole mutant, the MMR deficient, P53 mutant, and P53 wild type. And these groups confer clinical, prognostic information as well as treatment strategies. So this is going to be the future of classification of endometrial carcinomas. Coming to the next important topic, endocervical adenocarcinoma, it is now stated that this development in the classification of endocervical carcinoma is one of the most important in the gynecological cancer classifications in the last 50 years. So this, we know that most of the cervical squamous cell carcinoma and all of the cervical squamous cell carcinoma and most of the endocervical adenocarcinomas are associated with HPV. But because of the prophylactic treatment of HPV vaccine, it is considered now that the HPV-associated endocervical adenocarcinoma is expected to decrease, and the non-HPV-associated endocervical carcinoma is going to, therefore, increase in its incidence. So endocervical adenocarcinoma is basically divided into HPV positive or HPV associated and HPV negative or non-HPV associated endocervical adenocarcinoma. The HPV associated endocervical adenocarcinoma has 2 distinct types: the NOS, which accounts for 75% of all endocervical adenocarcinomas, and its variant, which is the viloglandular type. And the second type is the mucinous type, which accounts for 8% of all endocervical adenocarcinomas. And this has the intestinal types, the signet ring types, and the invasive stratified mucin secreting carcinomas. And this is the usual type of endometrial HPV-associated endocervical adenocarcinoma, NOS, with the pseudostratified hypochromatic nuclei and apical mitosis and apoptosis, which is the hallmark of HPV-associated endocervical carcinomas. This is the viloglandular type, subtype of the, this lesion. The mucinous types, the intestinal type has more than 50% goblet cells. The signet ring cells has more than 50% signet ring cells. Sorry, क्या कर रहा है? ऊपर प्रोजेक्ट कर रहा है? Okay, sorry, कहाँ से करूँ? यहाँ से करूँ? Oh, okay. All right, and okay, I'll just do that. And the mucinous NOS type has mucin secreting cells in greater than 50% of the mucin secreting mucin in greater than 50% of the cells. The ISMILA, or invasive stratified mucinous carcinoma, is associated with the stratified mucin-producing intraepithelial lesion, and is again an HPV-associated mucinous type of carcinoma. Non-HPV-associated endometrial adenocarcinoma includes gastric type, which accounts for 10% of all endocervical adenocarcinomas. The second most common type, clear cell carcinoma, 3%, endometrioid 1%, serous 0.5%, and mesonephric carcinoma is only 0.3%. Gastric type, as I said, it's 10% of all endocervical adenocarcinomas, range from very well differentiated, minimally deviated adenocarcinoma to poorly differentiated adenocarcinoma. And 10% of these tumors are associated with Peutz-Jeghers syndrome. In sporadic cases, P53 is the most frequently mutated gene. Clear cell carcinoma, we all know, is associated, or it is, is caused by intrauterine exposure to diethylstilbestrol to the females, or it is, or has a history of, if the patient has a history of cervical endometriosis, and accounts only for 3% of endocervical carcinomas. Mesonephric carcinoma, a rare tumor, arises from the mesonephric remnants. So the main difference between the HPV-associated and non-HPV-associated, HPV-associated are seen in younger individuals. They're smaller tumor size. They have better prognosis as opposed to the non-HPV, which is seen in older patients, have larger, bulky tumors, and have poor prognosis. And histologically, the most important thing is that you see floating mitotic figures and apoptotic bodies on scanning magnification in the HPV-associated endocervical adenocarcinomas. And of course, this will be positive for P16 and then HPV markers. So the take-home points for endocervical adenocarcinoma, that the IECC has segregated endocervical adenocarcinoma into HPV-associated and non-HPV-associated tumors by morphology alone, and which can be validated by P16 and HPV testing. HPV and HPV-associated and non-HPV-associated are biologically, clinically, and prognostically different tumors. 15% of endocervical adenocarcinomas are non-HPV types. Gastric type is the second most common subtype and most common type of non-HPV-associated endocervical adenocarcinoma. And mucinous carcinomas can be both HPV-associated or non-HPV-associated because they can include intestinal type, signature type, NOS, stratified, invasive stratified mucin tumors, and gastric type, which is the non-HPV-associated tumor. And finally, the vulval squamous cell carcinoma. We know that 80 to 90% of the vulval malignancies are vulval squamous cell carcinomas, and they have a high risk of severe morbidity with treatment. Again, vulval squamous cell carcinomas are divided into HPV positive and HPV negative, and the HPV negative are further divided into T53 mutant and P53 wild type. And HPV-associated ones are 60% of all the tumors, HPV negative, P53 positive 30%, and both negative 10%. They're seen in premenopausal in the HPV-associated type, postmenopausal in the P53 type. Risk factors include smoking and immunosuppression in the HPV type, and inflammatory dermatosis and lichen sclerosis in the P53 types. Precursor lesion is an HCL, HSIL in the HPV-associated, and the differentiated when in the P53 positive tumors. And the outcomes is slow progression with the HPV types and good outcome, and with the P53 mutant types, the progression is fast and this outcome is poor. So the take-home point that the vulval squamous carcinomas should be stratified into HPV and non-HPV types, which are clinically and prognostically important, and HPV-independent group should be further stratified by P53 mutation status. Okay, just to end with a more light note, when I'm not doing histopathology, I do calligraphy, and I paint, and I thank you for your appreciation. Thank you.
Thank you, Dr. Naveen, for such an enlightening talk. Now I would like to call upon our next speaker, an eminent histopathologist from Shifa International Hospital, Islamabad, Dr. Nadira Mamoon. Please welcome Dr. Nadira Mamoon.
Bismillahirrahmanirrahim. Good morning to all of you, and thank you to the organizing committee for giving me this opportunity to present my take on triple negative breast cancer and the challenges for a histopathologist. So, alluding diagnosed this last week in our department. So you can see it's a very angry looking breast tumor in a core biopsy, and there is a necrosis in the lower part of the slide, and you can see the highly pleomorphic tumor cells. They're triple negative on immunohistochemistry for ER, PR, and HER2, and a very high Ki-67 index, which is more than 80%. This is another case which was diagnosed a little time back, and this was a 72-year-old female. On a core biopsy, we saw a relatively better differentiated tumor, grade 2, and this was showing a lot of desmoplasia. This was, to our surprise, this was also ER-PR negative and HER2 negative, and had a very low Ki-67 index. This was less than 10%. So this was a bit of a challenge for the oncologists, and when it was discussed in the tumor board, they requested us to do the androgen receptor, and this was diffusely positive. So this belongs to a subgroup of triple negative breast cancer. So what I want to emphasize is that triple negative breast cancer is a very heterogeneous group. This confusing circle is from a recent article in Cancer Biology. And if you look at the central part of the figure, you see the 4 groups. These are the main groups which WHO has put these tumors into. But the surrounding spheres, they represent the differences in the DNA and the mutation profiles and the RNA and the protein expression. So these are made up of a large number of different types of tumors, which are broadly, then they are grouped into 4 groups, which are the 4 molecular subtypes of triple negative breast cancer. Previously there were 6 groups, now they have been compressed into 4 for the time being. So androgen receptor, the luminal androgen receptor group, which is the one which our case belonged to, they make up 15 to 25%. And then there is a mesenchymal subgroup. The luminal AR group, they respond to TKIs. So they have a different type of, and they can be targeted with the androgen expressing tumors therapy that is similar to what they give in prostate cancer and so on. Then there is a basal-like. We know about the basal-like, that has been around for some time, but now it is further subgrouped into immune-activated and immunosuppressed. The immune-activated group is the one in which you see a lot of TILs in the slide. On the core biopsy, we see sometimes that there are lots of lymphocytes. So these tumors, they respond well to the checkpoint inhibitors. And this makes up to 30% of triple negative, whereas the immunosuppressed make up to almost 40%. So basically, different targets in all these different types of triple negative breast cancer. We must remember that we are these days diagnosing most of these breast cancers on core biopsy. So there is an inbuilt limitation that you have a very scanty amount of tumor tissue. Sometimes if only the edge of a core is involved, so we have very little tumor to work with. So when we are diagnosing triple-negative breast cancer, I think the challenge for a pathologist is that we must ask ourselves 3 questions. Is it primary breast cancer? Is it truly negative breast cancer? And then, is it the typical invasive breast cancer, no specific type, of which the triple negative is a hormone receptor type which does not express? So, when we are talking about whether it is primary breast cancer or not, we are, of course, we have to rely on the history, the clinical radiological findings, but we must also then look, if the morphology is not typical, we should look for the breast differentiation markers. And our workhorse is GATA3, which is positive in up to 70% cases of triple negative, SOX10 in up to 80%. Mammoglobin and GCDFP, they are usually negative, have low sensitivity. If you apply GATA and SOX10, both of them, it increases the sensitivity, but still it does not pick up 100% of the triple negatives. So there is another marker which has recently been discovered, which is the TRPS1. And this was discovered in the pediatric age group. It is a pediatric skeletal abnormality. This protein is related to GATA3. It is a nuclear transcription factor. And by chance, it was found that it is expressed in almost all breast cancers, 100% and 86% in triple negative breast cancer. So when and if inshallah, this antibody becomes available to us also, then it will improve the sensitivity when applied in combination with other marker like GATA3 or SOX10, because it is not 100% specific. It does occasionally stain other tumors. Then we must also be cognizant of the fact that control, are we applying useful tip is if the Chi67 is totally negative, then that means there's something wrong either with the staining process or with the tissue. There are certain uncommon types of triple negative breast cancer which also should be kept in mind. Some of them are easily recognizable, like carcinoma with apocrine features. But I think when I think back, I think the neuroendocrine carcinoma, like the small cell neuroendocrine carcinoma, if we're not thinking of it, we might miss it on a core biopsy because it would look like a very angry looking basal type of tumor, and if we don't apply a neuroendocrine marker, we might just report it as a run-of-the-mill triple negative. Similarly, the large cell neuroendocrine cancer, although it's very rare. The small cell makes up 0.1% of all breast cancers. So although this is a very small proportion, but if you look at all the breast cancer that we report in every department, almost every day, so we should be seeing some small cell neuroendocrine cancer. I have not I can't think of any case that I have reported as a primary small cell in the breast. So we might be missing these cases. So just to draw your attention to that. If there is associated invasive breast cancer or DCIS, then we can be sure that it is a primary small cell. But if there isn't, then we can apply GATA3, which may be positive. TTF1 may also be positive because that can be positive in visceral breast, small cell, doesn't necessarily have to be lung. Then I'll skip to the rare salivary gland tumors. These are also triple negative. They are subtypes of breast cancer, but they are not subtypes of the conventional. They are rare salivary gland tumors, but they are all triple negative. They have a relatively low Chi index, and they are indolent tumors. So it is important to recognize them for that reason. And the adenoid cystic carcinoma, especially the solid basaloid type and the type with high-grade transformation, these might be difficult to recognize. For example, if you got this core biopsy, I think I could easily call it an invasive breast carcinoma and go on to the next case. And unless we think that it could be adenoid cystic carcinoma of the solid basaloid type and apply the necessary markers, we might not diagnose it. Similarly, adenoid, this picture showing a solid sheets of cells in an adenoid cystic carcinoma. Actinic cell also could present a challenge unless we focus on the granularity of the cytoplasm and apply DPAS and so on. And remember, these are small cores that we are talking about. Polymorphous adeno is very rare in the breast, but it does occur and it can also be confused. Want to talk a little bit about HER2/neu. Now, HER2/neu expression is one of the defining features of triple negative, that it should be negative. And we know that it is expressed on the membrane, and we have all been very vigilant about diagnosing HER2/neu 3+, because that responds to trastuzumab therapy. But now there is a paradigm shift in HER2/neu. So now it has been found that HER2/neu 1+ and 2+ cases, which are non-amplified, so the 2+ goes for fish. If it is non-amplified, even then these cases may respond to some targeted therapies which have been developed. And that is that the trastuzumab has been modified in such a way and conjugated with certain other antibodies and drugs that the systemic effects have been minimized. So now patients have yet another therapy which is available. And the difference is that the HER2/neu 3+ cases, they have more than 2 million molecules of HER2 on the cell membrane of the tumor cells. Whereas the HER2/neu 1+ and 2+ cases may have up to 5 lakh molecules on the cell surface. So if previously the therapy, the HER2 targeted therapy, it was restricted to 3+ because it had a lot of systemic side effects. But now the drugs have been modified in such a way as to reduce the systemic side effects, because the whole antibody drug conjugate is internalized and the payload of the cytotoxic therapy is released inside the cell rather than on the surface. So it does not damage the surrounding cells, and it does not go into the bloodstream. So there are ongoing trials for these HER2 low expressing tumors, and especially in the metastatic setting, they may be, a lifeline for the patients. So what I want to emphasize is that we have previously not been paying too much attention to the 0 and the 1+. So because once it's negative, we thought it's okay. But now we must be more vigilant in diagnosing the 1+ tumors. And the category for 1+ is that there is an incomplete membrane staining that is faint or barely perceptible in more than 10% of the tumor cells. If it is less than 10% of tumor cells, and if it is, there's no staining, then it is HER2 0. So the 1+ cases would be then amenable to some therapy, and now the oncologists have started asking for this, even though it is not part of the PAP recommendation yet. So even we have not put it in our reports, but they are coming back to us to ask if it is definitely 1+, because these patients can respond to different drugs. So the jury is out about the ongoing trials and what the response rate is going to be, but this is the thing that I think it will come up in some time. So the take-home message for my talk is that this is a heterogeneous group, triple-negative breast cancer, and we should keep in mind the rare tumor types which may be triple-negative and which may be missed on a core biopsy if we're not thinking of them. And we must ensure the primary status of the tumor and the triple negativity, and we must do accurate scoring of HER2, 1+ and 0. So thank you very much for your patient listening, and these are the some of the references which in the next slides. Thank you very much.
Thank you, Dr. Nadra, for such an outstanding presentation. Please welcome our next presenter, an amazing pathologist from Aga Khan University Hospital, Dr. Romana Idris.
Assalamu alaikum, and thank you so much. I'm really thankful to the organizing committee for giving me this opportunity. So the topic of my talk is an approach to challenging breast core true-cut biopsies. So I don't have any disclosure to reveal. So outline of my presentation is that I will cover the papillary lesion and true-cut biopsy, how to approach papillary lesions, then spindle cell lesion, and then somewhat practical tips regarding how to differentiate between fibroadenoma and phylloides tumor and the true-cut biopsies. So now in the last decade, the reporting of breast tumor is changed over time. Now the true-cut biopsy of the breast plays a central role in the diagnosis of the breast tumor. Now before that, FNA was a diagnostic entity, but now the true-cut biopsy is an essential role. So the true-cut biopsy provides sufficient amount of tissue for the pathologist to make an accurate histological diagnosis. Sometimes it is the only tissue for the patient, as most of the time now, after the advent of the neoadjuvant chemotherapy, there are no tumor left in the mean specimen. So this is the only tumor which we have for the patient. So while reporting the true-cut biopsy, one need to be careful regarding the immunohistochemical workup, so that we need to keep in mind that we need to save the tissue for the hormonal profile. So the first case is a 44-year-old female, and she presented with a breast lump. So as you can appreciate, on low power magnification, these are the multiple fragments of a neoplastic lesion showing solid nest. So here you could appreciate these solid nest on a bit higher magnification with thick fibrous septae. Here on high power, you can appreciate these fine fibrovascular cores in between these nests. And here the fibrovascular cores. This is the important clue. And you see these nests show low to intermediate grade nuclei with intervening these fibrovascular core. Presence of these fibrovascular core in the solid nest of tumor cells is an important clue in diagnosis of this entity. So this was cytokeratin CAM 5.2, strong positive. And this is smooth muscle actin. ESMA, as you all know, ESMA, it shows this type of staining. These are the small fibrous septae. But over here, if I show you in high power, now these are the fibrovascular core which is pointed out, and this is highlighted on immunohistochemical stain, smooth muscle actin. So differential diagnosis of this lesion is either it's a solid papillary carcinoma or intraductal papillary carcinoma or papilloma with DCIS. So basically it was solid. We diagnosed this case on a true-cut biopsy as features are consistent with papillary neoplasm, and solid papillary carcinoma is a likely possibility. Possibility of invasion cannot be entirely excluded. Then we just write a note on this report that papillary lesions are best classified on excision specimen. Then we receive the excisional biopsy, and you see these are the typical solid nest and expansile nodule of the tumor cells showing low to intermediate grade nuclei. And remember that if you are looking at the high grade nuclei, then don't think about papillary lesion. Nowadays, papillary lesions are reported as with high grade, grade 3 nuclei, but most of the time they show low to intermediate grade nuclei. So another magnification, and one can appreciate these fine fibrovascular core over here. Again, another magnification of the same lesion. So this is P63, which show loss of staining in the solid areas, and it could be seen around the periphery of these expansile nodule. However, they can be negative also. So solid papillary carcinoma on morphology show expansile nodule with a smooth contour and composed of a solid epithelial proliferation, and showing monomorphic cytological appearance with low to intermediate grade nuclei. They can show neuroendocrine differentiation, and intracellular and extracellular mucin is also appreciated. So they are usually CK5-6 negative. This is also an important immunohistochemical marker which is important in differentiating it from other lesions. They show diffuse strong ER positivity, HER2/neu negative, and clinically they are treated like in situ carcinoma. So case 2 is a 38-year-old female with nipple discharge. Again, if important clue on the true-cut biopsy is that if this lesion is a papillary, then you will see small fragments and small fragments on the true-cut biopsy lying in different ways. these are the small fragments. The papillary lesions are seen in like multiple fragments. You would not see an intact true cut biopsy in most of the papillary lesions. So this is showing intact one of the fragment which show intact myoepithelial layer and fine fibrovascular core. So this is routine run-of-the-mill intraductal papilloma. But now if you look at this bar, you see these are the normal intraductal papilloma, but this area show solid proliferation. So you are wondering what is this solid area which is unlikely seen in the papilloma. So this is a benign papilloma with this solid area. So this again the solid area composed of small monomorphic cells with low-grade nuclei. This is another magnification which showing papilloma with solid areas. And this is the smooth muscle actin. And this is the papilloma area which I show you. This showing intense intact myoepithelial layer over this area. However, the solid area show loss of staining. So this beautifully decorated by the immunohistochemical stain actin. Again, high power showing intact papillary areas, and now this is a solid area which show loss of staining. So this is papillary neoplasm, and differential diagnosis which we give is differential diagnosis include papilloma with ADH and papilloma with DCIS, convincing invasion not seen, and we added 2 comments. A distinction between these 2 entities is made based on size criterion, which is not possible on true cut biopsy specimen. And the comment 2, its papillary region are characterized best on excision specimen. Complete local excision is recommended. So this is the excision specimen. This is showing the solid area again, smooth muscle actin and P63. So in the excision specimen reveal papilloma with ADH. So the important point to remember is if the lesion is, the size is less than 3 mm, on the excision specimen we categorize as intraductal papilloma with ADH. However, if the focus is more than 3 mm, then you would classify it as intraductal papilloma with DCIS. And if the focus show intermediate to high nuclear grade, then size criteria does not matter. So case 3 is a 36-year-old female, breast numb, and Dr. Nadra has extensively covered triple negative tumor, again showing multiple fragments, high nuclear grade, angry looking nuclei with necrosis, again high grade tumor, showing myxoid change, immunohistochemical stain, multiple keratins were performed, and it showed negative for all the immunohistochemical stains. So on true cut biopsy, we gave a diagnosis as spindle cell neoplasm. Differential diagnoses include metaplastic carcinoma, phylloides tumor, and soft tissue sarcoma, and in order of preference. So excision specimen received, it was a metaplastic carcinoma showing epithelial and mesenchymal differentiation. And this is the area which I show you on the true cut biopsy. This myxoid area again seen in the excision specimen also. So while reporting spindle cell lesion on the true cut biopsy, it's always remember that you have to perform multiple keratins before ruling out a possibility of metaplastic carcinoma. I usually perform ceratokeratin CAF 5.2, CK7, A1, A3, 34, beta A12 in EMA before ruling out a possibility of metaplastic carcinoma. And you just remember that if all the keratins are negative, still you can't exclude metaplastic carcinoma. You need to keep it in the differential. And don't rely on single keratin, please. And it is our practical experience that phylloides tumor are usually large. They are mostly more than 5 centimeter in size, and metaplastic carcinoma is usually falls into the range of 3 to 5 centimeter. So while looking at the true cut biopsy, it is also an important feature to look out the stretched epithelial lining, which could be seen in phylloides tumor. So this is an important and helpful feature while if you are thinking between how to differentiate between metaplastic carcinoma and malignant phylloides tumor. So in the reporting of spindle cell lesion of the breast, don't forget to rule out a differential of fibromatosis and myofibroblastoma. Many a time I show my spindle cell lesions of the breast to Dr. Nasir for ruling out a possibility of soft tissue tumor. So, and important is that another important in category dermatofibrosarcoma protuberance. Need to remember that also as a differential because we have seen 21 cases of dermatofibrosarcoma protuberance. We have a collection of these cases. So a little bit about fibroepithelial lesion. It's important that fibroepithelial lesion to differentiate between fibroadenoma and phylloides tumor. So on the needle core biopsy, they show increased stromal cellularity, leaf-like pattern. However, fibroadenoma can be cellular, and phylloides tumor may show less cellular areas. So leaf-like pattern can be seen in fibroadenoma. So our life is not so easy. It's not easy to distinguish between fibroadenoma and phylloides tumor. So complex fibroadenoma, juvenile fibroadenoma, they are usually misdiagnosed as phylloides tumor. So we need to keep in mind regarding this entity. So multidisciplinary approach reduces the number of phylloides tumor missed on core biopsy. So the key findings which are predictive of phylloides tumor on a true-cut biopsy are the fragmentation of the fragments. There would be fat or adipose tissue infiltration, stromal cellularity, subepithelial condensation, and even number of mitosis. Dr. Naila usually say one mitosis in the stromal component is quite characteristic and feature of phylloides tumor. So for cases which are challenging to classify between fibroadenoma and phylloides tumor on core biopsy, so remember, if you are in doubt, please give differentials. What happened? They would excise the specimen, so don't hesitate over it. So what I recommend is that I would write cellular fibroepithelial lesion. Differential diagnosis includes cellular fibroadenoma versus phylloides tumor. Careful radiological pathological correlation and complete excision is recommended. Similarly, for phylloides tumor, if you are not sure whether it's a benign or borderline phylloides tumor, you can write phylloides tumor, low-grade histology, explain the grading challenge in the comment, and categorize that possibility of more aggressive areas in the adjacent vicinity cannot be entirely ruled out. So if you are unable to differentiate between the two. So points to remember whenever you receive a true-cut biopsy, you need to keep these points in mind. Either I'm looking at the run-of-the-mill IDC, or is this any specialized variant? I'm looking at any rare variant, and either it's a mixed ductal or lobular, either it could be a micropapillary component, because the presence of micropapillary component imparts an aggressive prognosis, and it shows more chances of lymph node positivity. Either I'm looking at with neuroendocrine features. Is this a metastasis from elsewhere? Could it be lobular? Especially pleomorphic lobular could look like routine invasive ductal carcinoma grade 3. So one need to do E-cadherin stain, or if I am looking at a papillary lesion. So it is important to recognize papillary lesions on core biopsy. And most papillary lesions, especially a solid variant of papillary carcinoma, it can be misdiagnosed as IDC on core biopsy. So presence of fine fibrovascular cores, which I have mentioned multiple times, and the immunohistochemistry, smooth muscle actin, my favorite marker, they are important in reaching to our definite diagnosis. So it is important to perform multiple cytokeratins before ruling out a possibility of metaplastic carcinoma. And don't forget to rule out the differentials of fibromatosis and myofibroblastoma in reporting spindle cell lesion of the breast. Keep dermatofibrosarcoma protuberance also in the mind while reporting spindle cell tumor. So improving diagnostic accuracy of the core needle biopsy is likely to be best achieved by a combination approach, which includes increased number of the cores by the radiological findings and mammogram and ultrasounding finding, and the expert opinion from the breast pathologist, and consultation with the treating surgeon. Sometimes a call for the surgeon is also very helpful. They will discuss their differentials, and it's really helpful. Thank you so much.
Such a fine presentation. Thank you so much, Dr. Romana. Our next presenter is a wonderful histopathologist from Fatma Memorial Hospital, Lahore, Dr. Qasim Ahmed. Please welcome Dr. Qasim on stage.
First of all, thanks to the organizing committee for the kind invitation. I'll go straight to the presentation. Reporting cytology of FNA of salivary glands, difficult subject for most, and the Milan system of reporting has been introduced, so let's discuss briefly about that. challenges that we see in salivary gland cytology are, although they are small organs, but they are in the Blue Book of WHO, they are now, at the moment, more than 30 distinct tumors. So that in itself is an issue. Organ like thyroid would have only few tumors, but this is distinct 30 plus at the moment. In addition to that, these tumors have got intratumoral heterogeneity. So one area of the tumor may look like something different than the other area. And then to top it all, there is overlap among many tumors. So as we know, that's another challenging point. So with all this confusion, there is definitely reporting confusion. So we used to give descriptive diagnoses. We used to have our own categories. I may be doing something, somebody else will be doing something else. And a lot of us will be using the surgical pathology terminologies because we were familiar with that. So among the experts, it was agreement that something should be done about that. And we need to have diagnostic categories for which we can communicate easily what I'm saying, other person should understand. And the data could be exchanged and improved upon for the future. So they came out with the Milan system of reporting published in 2018, just before COVID. And so I suppose COVID hampered its acceptance to a slight extent. So what they were emphasizing in this Milan system is that although you need to give specific diagnoses of if you can, but rather put them in categories which have got risk of malignancies attached to that so that proper management is done by the clinician. So we have here 6 categories ranging from non-diagnostic all the way down to malignant. And as you go down towards the malignancy, the risk of malignancy increases. We note here that the non-diagnostic has got a high risk of malignancy. And within the neoplasm, there are 2 separate categories. One is benign, and the other one is salivary gland neoplasm of uncertain malignant potential, which is SUMP. So I'll be concentrating on these 3 entities. The rest, I think, most of us are at ease with slightly. When you are sure about characteristic benign tumor like pleomorphic adenoma or Warthin's with characteristic cytologic features, there's no problem. And most of the tumors are from these 2 in the incidence-wise. And when you are sure of malignancy, it is quite, it turns out to be malignant with characteristic malignant features. If you've got on cytology, it turns out to be histologically malignant as well. So what to make of these 3 entities, which I'm going to emphasize because of the time constraints that are here. On itself, AUS is no histopathology. There's no disease entity as AUS. There's no disease entity as SUMP. So these are cytopathological diagnoses, meaning that the cytopathologist is having a bit of difficulty in actually pinpointing the type of tumor because of the nature of aspirates and the lesion itself. So let's go over these. What is non-diagnostic? Obviously, you've got no cells or low cellularity specimen, but there are exceptions in salivary gland cytology to that. And those exceptions are, if you've got matrix material, even though hypocellular or no cell, but you're not going to call it non-diagnostic. If you've got mucinous cyst contents, you're not going to call it, even though there are no epithelial cells, or very few epithelial cells, you're not going to call it non-diagnostic. These 2 are very important. Obviously, with cytologic atypia, you obviously are not going to call, but even in low cellularity specimens. So because the risk of malignancy is 25%, it's important. Why? So if you've got an aspirate which shows normal SNI of salivary gland and normal ducts, so if you call this as benign, in the presence of a well-defined lump clinically, then this is sampling error. You're not going to call it benign disease or non-neoplastic because you haven't sampled. If there's a lump, then this should not be non-diagnostic. It should be cautionary note given that this is non-diagnostic because we have not sampled the lesion. So this comes in the presence of a well-defined lump. Obviously, you won't be poking your needle on a normal face, you know, it has to have a lump. So if in a lump, if you're getting this material which is normal SNI and normal ducts, then it's a sampling error, and it's put in non-diagnostic so that you can say that the lesion has not been aspirated. A repeat under ultrasound guidance or otherwise should be done. Similarly, if you've got a non-mucinous cyst contents, so non-mucinous cyst contents, same. You haven't aspirated, you have aspirated the lesion, and it's a cystic lesion, but we haven't got the epithelium to tell what it is. So it should be again under ultrasound guidance. Any solid area or epithelium should be tried to sort for. So this comes under non-diagnostic. Another thing to note is that sometimes you get a bloody specimen with very few inflammatory cells. So we put this in non-diagnostic because you can't put it in just inflammatories. There are very few inflammatory cells, or benign or non-neoplastic category. Because sometimes neoplasms get infarcted and then they get inflammatory response to it. So we have to put this as non-diagnostic so that we can evaluate it further in his, radiologically and get proper sample. For AUS, one thing to say is that it shouldn't be this is not AUS. So another case is this acellular matrix material. As I mentioned, please don't call it non-diagnostic because definitely there's a lesion here with producing a lot of matrix. So as we'll discuss, this has to have a, don't put non-diagnostic on that. Non-neoplastic category is we are dealing with chronic silenitis, reactive lymph nodes, granulomas, all that thing. So you'll get inflammatory reactive yields. There are interparotid lymph nodes, which you have to remember, they can be reactive lymph nodes there. Obviously, there is no cytology of a neoplastic process here. So the examples would be reactive lymphocytes with lymphocytic aggregates from a lymph node, which is hypoplastic, a granuloma, a stone calcifications with debris in the background, probably obstructing the ducts. Now, this may cause problem if you don't look at the background lymphocytes. You know, there's a lot of lymphocytes here, and these are reactive ductal cells. So this is a case of chronic silenitis, but an untrained eye may look and call it as an AUS. So AUS basically is indefinite, cannot exclude neoplasm. So when you're putting it in the AUS category, we are not sure whether it's a reactive or is it a neoplastic. The confusion is between a reactive process and a neoplastic process. Most of the time, these are poorly sampled specimens, or they are compromised because of blood clots that are overshadowing the cellular details, or air drying artifact, which is very common in our community practices. Prevalence of this should, in a department should not be more than 10%. So not put everything in AUS, you know. So what are these AUS then? You've got reactive reparative atypia, indefinite for neoplasm. Any metaplastic changes that bothers you, indefinite for neoplasm. Low cellularity specimens with some cells that are present are not diagnostic of neoplasm. Artifacts that cause you problem. And here you put the mucinous cystic contents. When you are acellular or hypocellular mucinous cyst content specimens, they are not non-diagnostic, they come under AUS. And reactive lymph node population, which we're not sure is reactive or neoplastic. So a lot of abundant mucin, not sure, it has to come under AUS. You cannot exclude a low-grade mucoepidermoid carcinoma from a retention cyst in such a case. Then you've got lymphoid background, but rather than having these solid clusters of metaplastic cells, to call it Wardens, you've got these few isolated oncocytic cells. Is it a reactive metaplastic change in chronic silenitis, or are we dealing with neoplasm? So comes under AUS. Or very sparse or low cellularity groups of oncocytic cells. Not sure whether this is oncocytic metaplasia or oncocytic tumor. Comes under AUS. This I've taken, some of the pictures I've taken from the Milan System Atlas. Very important what they call AUS. Huh? So a non-mucinous cyst contents with very rare epithelial cluster. You're not sure what neoplasm or reactive changes this could be. So we put into AUS. Very low cellularity specimen, which has got atypia and degenerative changes, put under AUS. cellular details masked by blood clots. You feel that this could be oncocytic lesion, but you're not sure. So again, AUS. Or you've got a keratinizing, rare cluster of keratinizing epithelial cells. You're not sure whether it's inflammatory induced or is it neoplastic. Put under AUS. What is SUMP then? SUMP, you are sure it's neoplasm. AUS, you are not sure it's neoplasm. It's reactive versus neoplasm. SUMP, you are sure it's a neoplasm, but you cannot further categorize it, or you're not sure whether it's benign or malignant. So this is where SUMP comes in. You are dealing with most of your cellular specimens, which are basaloid, oncocytic, or clear cell, without the typical features of benign or malignant. So they are lumped into the SUMP category. Prevalence is around 10%, and the risk of malignancy is higher here. It's about 35%. So again, from the Milan system atlas, this is in a background of pleomorphic adenoma. When you see these clusters of metaplastic squamous-looking cells, or squamous sort of cells, is it a metaplasia? Or are we dealing with some atypia here that is carcinoma developing here? Not sure, SUMP comes in. Background of pleomorphic adenoma, and you've got these atypia here. Not sure, are we dealing with reactive metaplastic atypia, or reactive metaplasia, or are we dealing with a malignancy arising? Comes under SUMP. Basaloid cell collections. Cellular, when it was very rare occasional cluster, then you put in AUS, but if you've got cellularity, you can't put it AUS, you have to put it in, you're sure it's a neoplasm. But we are not sure what type, or whether it's benign or malignant. So we are not sure it's basal cell adenoma or a carcinoma. Basal cell carcinoma differentiates from adenoma that is infiltrative. We can't tell on cytology. Or we are not sure it's cellular PA, or it's an adenoid cystic. So you put it in SUMP and give the differential here. Now these cases that before this, classification came out, Milan system, these are my own cases, and we used to give us detailed sort of descriptive, basaloid tumor with matrix, could be this, could be that. This turned out, and I'll tell you later on, this turned out to be pleomorphic adenoma with areas showing this sort of appearance. Here there was this band-like, basement membrane-like matrix. So differential was, could it be basal cell adenoma, canalicular type, blah, blah, blah. And this turned out to be, monomorphic adenoma, basal cell adenoma. But this, which looks very much like this, turns out to be epithelial myoepithelial carcinoma. So here we have to lump them in SUMP because we're not sure which one is benign and which one is malignant because of the nature of how the lesions are. And even in histology, it gives us a lot of issues. This is a recent case. So these were before the times of Milan system, but this was recent. And so we put it in the SUMP category, and it turned out to be a monomorphic adenoma later on. SUMP can also include these monomorphic myoepithelial cell population. In the background could be cellular myoepithelioma, could be cellular PA, could be myoepithelial carcinoma. So you have to put it in SUMP. I'm running short of time. I'll skip these spindly sort of lesions. Could this be spindle cell rich, myoepithelial spindle cell rich PA, or could this be a soft tissue spindle cell lesion? Oh, I'll skip these. I would like to spend the last couple of minutes on what's happened after this system came out. So people started putting Milan system in their retrospective studies. So this study came out of India, and they put a retrospective study of their previous cases with histologic follow-up in 118, and they found out that whenever they put something in AUS, it turned out to be malignant histologically. So their criteria for putting AUS threshold was very low. And they have to improve themselves, not abuse this category. So this confidence level was low, and they were putting in AUS, all of these turned out to be malignant. Similarly, from South Korea, this came out, same problem. The suspicious for malignancy and benign neoplasm categories were abused and used much more commonly that is recommended by the Milan system. So self-audit and self-teaching comes here. A study that came out from USA, whenever they call anything malignant, people are quite sure they all turned out to be malignant in this in the histology. And similarly with suspicious for malignancy, the rate was equal to what the Bethesda was recommending. So, and they say the help of ancillary studies improve your confidence and definitive diagnosis. All the younger generation knows this by heart for the exams, and later on, I have to look into the book. So you know it better. Most of these molecular features are now being translated to immunohistochemistry. I'll finish my talk on this. Give me a couple of minutes if you can. The Milan system, while it was being introduced, the authors and the experts there, they did a consensus on certain diagnoses, and they sent the images with their, as a questionnaire to the practicing pathologists who were doing cytopathology in USA and even abroad. And they asked for their diagnosis. And I'll tell you, the most discordance that came was in the presence of acellular materials. People were calling them non-diagnostic. They were in benign cells were present in the presence of a lump clinically. They were calling it non-diagnostic. And clear cell basiloid morphology. That's why I touched these areas at the moment. And the second point, which I suppose the policymakers would agree with me, that the best results came out from those who had cytopathology fellowships or the boards. And we should look forward to that in our practices, that we need to have confidence in our training. Thank you.
Thank you, Dr. Qasim, for such an informative talk. Next, we have got an exceptional histopathologist, Dr. Saira Fatma from Ahan University Hospital, Karachi. Please welcome Dr. Saira on stage.
Assalamu alaikum. Thank you for the organizing committee for giving all of us this opportunity. And my personal thanks to Nasir for facilitating this full screen PowerPoint presentation. So since Dr. Qasim has already led the foundation for my talk, I will get directly to the business. What is the WHO update? So there are less things as compared with some other WHO updates, and these are more manageable. Nothing to disclose. So they have given this outline that there are certain new entities. They have omitted some of them, and there are still some unsettled issues. Of course, nothing is now defined by any morphological pattern. There are genomic alterations which are part of the definition, and a bit on the grading system. So this slide looks busy, but for the residents to just grasp the message, keep on the new entities. The green ones are benign, okay? And I think these are gray. Gray ones in the new entities are malignant. So first I will tell you that the sclerosing adenosis, sclerosing polycystic adenosis, which was a non-neoplastic lesion, it has now shifted into the benign neoplasm because now there are molecular alterations and enough evidence validated that it should be categorized as benign. Keratocystoma, intercalated duct adenoma, striated duct adenoma, these are interesting, so I will touch upon them. In the malignant categories, microsecretory. There is a secretory carcinoma of the salivary gland, so now there is a microsecretory. It's not dependent on the size. We will look into the morphology. And sclerosing microcystic adenocarcinoma. So we know that there is a microcystic adnexal carcinoma. So we have taken the concept from there, and sclerosing microcystic adnexal carcinoma is the salivary gland counterpart of the cutaneous one. Mucinous adenocarcinoma, so they have omitted some of the categories which are not exclusive for the salivary gland. They be mesenchymal tumor, hematolymphoid. So these will not be categorized as a separate entity. A distinct subtype, cribriform adenocarcinoma, which is still in the chapter of polycystic adenocarcinoma as a subtype. So unsettled issues, one are the poorly differentiated carcinoma, oncocytic carcinoma, and IPMN, thus analogous in the pancreas. So intraductal papillary mucinous neoplasm, it is an emerging entity, and they have described under the outline of that one. So the last column is easy, as Dr. Qasim said, for the residents, not for me. I am an old-fashioned, so I cannot remember all these. So just to recap, these are the new entities, and they have included only well-documented new entities. So how can we remember sclerosing polycystic adenoma? Remember anything which looks like fibrocystic change in the breast and is now, we are looking in parotid or any other salivary gland. So it will be a well-circumscribed lesion, fibrosis, cyst, apocrine change, proliferation of the ductal cell, acini, and most importantly, there will be, so I cannot choose the, I think, yes. So most importantly is these intracytoplasmic granules which will come into the picture. So a one well-circumscribed one, cyst, and apocrine change. So this is the slide which shows intracytoplasmic hyaline granules. And the most importantly, why it was put into a neoplastic one, because there is PI3K pathway alteration, and the most common one in this pathway is the P10. So that is the reason from non-neoplastic to neoplastic shift. So how can we remember? So anything fibrocystic change, looking like fibrocystic change in the parotid or salivary gland, it's sclerosing polycystic adenoma. And the important thing is that the cells will be positive for, both cells will be positive for keratin, and they will be negative for the CEAP53 HER2, S100 variable positive. So the ductal cell population may also show positivity for androgen PR-ER. So it leads to something important. And what is important, that although there is no patient yet who developed METs or died of the disease, but actually 3 patients had invasive carcinoma of apocrine ductal type. So they think that this sclerosing polycystic adenoma is closely related to apocrine intraductal carcinoma or high-grade salivary duct carcinoma, and because of these PI3K alteration. And they have written that it might be the spectrum of precursor lesion, but not clear yet. So keratocystoma, benign entry. Remember, multiple cyst, benign, lined by the stratified epithelium, without granular layer. Essential criteria is bland, stratified epithelium, no granular layer, no atypia, no invasion. Okay, so no worry to take into squamous cell carcinoma. This is important, intercalated duct lesions. There are 2 entities, hyperplasia and adenoma. So the adenoma is, cytologically, they have profile of the intercalated duct. So we will see what is the profile of the intercalated duct, but these are proliferation, and remember, bilayered. Intercalated, bilayer. And the other one will be striated duct adenoma, single layer. So these have eosinophilic to amphiphilic cytoplasm, myoepithelial layer, although inconspicuous, but it is there. It will be highlighted by S100 or P63. So this is the picture, and it shows a slightly blue, but the stroma is less, and these are bland appearing cells. Striated duct adenoma, in contrast, it is monolayered, and it resembles normal striated duct, no myoepithelial layer or basal layer. So striated duct adenoma does not show positive staining for SOX10, but it does for S100. While intercalated duct adenoma, it exhibits both S100 and SOX10 positivity. So these are closely they might be confusing, but we have to look for the morphology and the myoepithelial layer and then for the markers. The malignant categories, the microcystic adenocarcinoma, it is a low-grade salivary gland adenocarcinoma, and defining mutation is this, MEF2C fusion. There are small tubules, microcysts, which are lined by the flat and intercalated duct-like cells. So there is some luminal secretion, nuclei are uniform, there is no atypia, no nucleoli. They do not have myoepithelial layer, so that is the reason they are monophasic. Very well circumscribed, there might be some focal infiltration into surrounding tissue, and none of the 24 cases till date, they had shown recurrence or distant mets. So this is the picture. This is microcystic adenocarcinoma. It has small tubules which have flattened cells and no myoepithelial layer. And they will show positivity for S100 and SOX10, as we mentioned that their profile is like intercalated duct. So this is the P63 stain, which is showing diffuse positivity and small tubules with luminal secretion, bland nuclei. The other category is sclerosing microcyst secretory adenocarcinoma. So sclerosing, we know there will be abundant stroma and small tubules which have, which may be present in nest. So desmoplastic stroma and small tubules. Rearrangement of the MIB gene is seen, which is the characteristic. And this is analogous to cutaneous counterpart. It is biphasic. जो microsecretory था, that was monolayered. There was no myoepithelial layer, but sclerosing one, it is biphasic. There will be myoepithelial layer, and okay. There are areas of debate, new entities, emerging entities. The one is intraductal carcinoma. It means previously it was described as low-grade salivary duct carcinoma, and we are recalling again the breast. Anything which looks like atypical ductal hyperplasia or DCIS, think of intraductal carcinoma, intact myoepithelial layer, proliferation may be solid, cribriform, papillary. So in situ nature is shown by the myoepithelial layer, and it has intercalated duct phenotype, means S100, SOX10 both positive, and the characteristic arrangement is of the read gene rearrangement. So this is again, we have seen a lot of beautiful cases of the breast, so this reminds us of the low-grade DCIS, and which is SOX10 positive. The C and D picture taken from this article below, they show apocrine change, and that is depicted by the positivity for the androgen receptor. And there are apocrine change, cystic change. P63 highlights myoepithelial layer. So intraductal carcinoma, basically in situ type lesion. So these are some gene rearrangement. The important thing is that probably myoepithelial and ductal cells, they have same fusion. So basically myoepithelial cells are part of the tumor. And that is the reason that some of the invasive neoplasm, they are actually, they will be intraductal carcinoma with invasive component. So another important subtype is cribriform adenocarcinoma, which is under the main heading of polymorphous and multinodular. There are uniform solid cribriform microcystic structure, glomeruloid papillary structures, and they are basically, they are higher risk of the lymph node metastasis. So papillary, glomeruloid, uniform, round with PTC-like nuclei, as we see in the polymorphous. Gene rearrangement are like that of the polymorphous, PRKD1, and with slight change, and that is the reason they are not sure that it is a different category or is a variant of polymorphous is still unsettled. Mucinous adenocarcinoma, we see maybe extracellular, intracellular mucin, and papillary significant colloid mixed type morphological patterns. And the important thing is the rearrangement, which is very characteristic for this type of tumor. And any mucinous carcinoma which we see outside, we should think of the primary as well and exclude METs before considering as primary mucinous adenocarcinoma. So they have taken the concept of IPMN because of the mucinous carcinoma, which is like in the pancreas, and it is emerging entity. They are still uncertain whether this is entities separate from mucinous carcinoma, probably related to ductal papilloma, or it is a precursor lesion, or is it an intraductal variant of mucinous carcinoma. So IPMN, just like pancreas, they will be looking at in the salivary gland as well. Circumscribed, tall columnar, pseudostratified epithelium. Regarding the oncocytic neoplasm, they think that probably oncocytic change is in the different type of other salivary gland tumor, and oncocytic carcinoma is probably, we don't know whether it exists or not, and it is not classified as independent entity. Carcinosarcoma is still in this emerging entity or unsettled part, and not sure whether sarcomatous component is true sarcoma or epithelial mesenchymal transition. So as Dr. Qasim has mentioned that there is limitation in the Milan system. WHO recommends use of Milan system. If core biopsies are received, then we have to be cautious. Do not attempt to label as carcinoma because we do not know the infiltrative nature or PNI. So the final resection specimen will tell us what is the exact nature of the specimen or the tumor. Genomic entities, there is a list which anyone can go and take a look. Regarding the grading system, there are systems which are validated for the adenoid, cystic, mucoepidermoid, and NOS, but it cannot be applied generically for every tumor, for every cancer. So it means that because certain tumor, they have intrinsic behavior, and universal grading system is not sufficient. So this is the summary slide, and we have to go back again and again for the to the book to check what we are looking at and are we correct or not. And thank you for your attention.
Thank you, Dr. Saira, for such a marvelous presentation. Please welcome our next speaker, Dr. Mulazim Hussain from Azad Jammu Kashmir Medical College, Muzaffarabad.
Bismillahirrahmanirrahim. Qabil Ehtaram Chairman, Chairpersons, Moderators, my teachers, and President of PAP and organizers. No doubt, आपने बहुत सारी चीज़ें सुनी. आज मेरा topic, it's not directly related to the histopathology, but it was the histopathology who first time diagnosed what is happening in the body with the corona. And it was the histopathology that after diagnosis, making the autopsy and making the histopathology, then they advised the steroids, and the steroids made the prognosis good. ये सब कुछ आपने सुन चुका होगा कि when the COVID started, पिछले साल 26 फरवरी को पहला केस आया, and I was in administration, and the government of Punjab advised me to give certain information in the Urdu to the peoples, and I am proud of this कि मैंने इतनी सारी information दी कि लोग मुझे अब histopathologist नहीं समझते, लोग मुझे अब, but anyhow, we are doctor and we all are suffer at this. This corona, आप सबको पता है corona क्या हुआ. पहले का जब नाम आया तो इसका नाम novel corona virus आया. ऐसा it's one, actually ये देखा गया कि जैसे इस तरह के और भी इस तरह के फैमिलीज एक तो आई जो सऊदी अरेबिया में आई, और उसके बाद ये कोवी-1 के नाम पे आया। बेसिकली हुआ ऐसे कि देयर आर अजम्पशंस कि कोई ऐसा स्किप हुआ फ्रॉम द लैब, वो जो चमगादड़ था वेंट इन आउटसाइड और उसके बाद वो मारा गया, वो मार्केट में आया, और इन दिस वे द कोरोना जो है स्प्रेड हुआ, और इतना खौफनाक स्प्रेड हुआ कि चाइना में आया, और आज भी चाइना की कल रिपोर्ट देखें तो राउंड अबाउट 40,000 केसेस, न्यू केसेस इन बीजिंग दे आर लॉक्ड। इसका मतलब है कि कोरोना इज स्टिल नॉट ओवर। पैंडेमिक बेशक ख़त्म हुआ लेकिन एंडेमिक ज़रूर ख़त्म हुआ। कोरोना के बारे में आपने पढ़ा, इसकी सबसे इम्पॉर्टेंट बात जो है वो इसकी स्पाइक प्रोटीन है। बहुत सारी प्रोटीन है, स्पाइक प्रोटीन है, बाकी सब प्रोटीन के अंदर इसकी म्यूटेशन नहीं हुई। जैसे आपने अभी कहा कि जीन म्यूटेशन फ़लाँ में आ गई, फ़लाँ में आ गई, फ़लाँ ट्यूमर हो गया, फ़लाँ ट्यूमर हो गया, तो कोरोना के अंदर भी सिर्फ इसकी स्पाइक प्रोटीन के अंदर म्यूटेशंस आई, जिसकी वजह से ये अब डेल्टा से ओमिक्रॉन की तरफ आया है। और अब पाकिस्तान के अंदर नो डाउट हम इसको नहीं देखें, ये दो डिफरेंसेस हैं। देखें कि डेल्टा और ओमिक्रॉन के अंदर कितनी म्यूटेशंस आई। जो रेड म्यूटेशंस हैं वेरी सीरियस थी। इस म्यूटेशन ने एक काम किया जो S1 S2 था, दो इस तरह की स्पाइक प्रोटीन थी कि जितना ख़तरनाक वायरस होगा उतना S2 S1 से अलग होगा, और जो S2 जो है वो इन्फ्यूजन करता है, और उसके खिलाफ जो है नेक्स्ट जनरेशन ऑफ जो वैक्सीन है वो इस तरह बनाई गई है कि बनाई जा रही है कि या उसके फ्यूजन प्रोटीन के बारे में बनेगी। अगर फ्यूजन प्रोटीन के बारे में उसकी वैक्सीन बन गई तो इट विल बी ऑल, कभी भी कोरोना दोबारा दुनिया में नहीं आएगा। एनीहाउ, जो ये नया वेरिएंट है जो इस वक्त चाइना में फैल रहा है, ये ओमिक्रॉन की एक नस्ल है BA.5, और अब BA.5 110.27, जो ये देखें कि बिल्कुल इसको अगर इसको देखें तो बिल्कुल ये बाहर आया हुआ है, वो ये नज़र नहीं आ रहा पूरा। एनीहाउ कि ओमिक्रॉन का BA.5 जो है बिल्कुल उसको देखें, लेकिन स्टिल इसके अंदर इतनी चेंजेस नहीं है कि हम इसको कोविड SARS-CoV-3 कहें। कम अज़ कम इसके अंदर 25 से 30% चेंजेस आएंगी, एंड इट विल टेक अनदर 5 to 6 years टू बिकम SARS-CoV-2। अगर इस तरीके से हम सुपर स्प्रेड को ना रोक सके, और अगर हम इसके एहतियाती तदाबीर ना, माई लास्ट 3 स्लाइड्स विल बी वेरी प्रीसियस कि हमें करना क्या है, स्ट्रेटजी क्या है कि हम उसमें देखें। इसके बाद देखें कि ये ओमिक्रॉन की जो बिल्कुल BA.1 BA.5 का था, बिल्कुल सेपरेट। ये निंजा आया कोई 2 माह पहले आया, और इसने बहुत ज़्यादा दहशत फैलाई। कोरोना की दहशत ऐसी थी पिछले साल में कि जो डेड बॉडी थी उस डेड बॉडी को भी लवाहिकीन के हवाले नहीं किया जाता था। वी रोट ए लेटर, वी राइट ए पब्लिकेशन, आवर पेपर वाज पब्लिश कि डेड बॉडी के अंदर जब डेड हो जाता है तो कोरोना भी डेड हो जाता है। तो दैट इज़ वाई उसके बाद पिछले साल मई में कि डेड बॉडीज़ को लवाहिकीन के हवाले करना शुरू किया। था दीज वर सर्टन अपडेट्स कि हम उसको किस तरीके से वक्त के साथ साथ, ये एडिशनल म्यूटेशन है, इसको वक्त जितना, हालांकि कहा जाता था कि इसके अंदर म्यूटेशंस कम हैं, लेकिन अब म्यूटेशन जो हैं वो इस तरह फैल रही हैं कि जैसे मैंने कहा 7 से 8 साल लगेंगे कि इसको कोरोना कोविड SARS-CoV-3 होने में। बहरहाल एनीहाउ इस म्यूटेशन से ये एहसास होता है कि कौन सी एंटीजन बन रही है और उसके खिलाफ कौन सी एंटीबॉडी। अब ये था कि चुगताई साहब जानते हैं कि पहले शुरू में जब ये कोविड लैब शुरू हुई प्राइवेट सेक्टर में और गवर्नमेंट सेक्टर में, उस तरह के किस तरह का जो किट आती थी, लेकिन ऐसा ऐसा जैसे कोरोना चेंज होता गया, उसकी कोविड के अंदर चेंज होती गई, तो उसके बाद किट को भी अपडेट किया जाता रहा। इसलिए स्टिल नया वायरस भी जो आया ओमिक्रॉन जो डिटेक्ट हो रहा है या BA.5 डिटेक्ट हो रहा है, उनको पुरानी किटें तो डिटेक्ट नहीं करी, लेकिन अपडेटेड किटें जो है ना वो इसको डिटेक्ट कर रही हैं। ये PCR को इवेड नहीं कर रहा। अब इसके बाद इम्पोर्टेंट थिंग इज क्या हुआ क्या, ठीक है। हम नो डाउट कि मेरा टॉपिक आपको डॉक्टर नायला ने इधर रख दिया, लेकिन एनी हाउ इट इज़ वेरी, आई एम सफरर। मेरे बेटी को हुआ, मेरी मिसेस को हुआ, मेरी बहन को हुआ, मेरी फैमिली में हुआ। दैट वाज द सीरियस सिचुएशन एट दैट टाइम। अब हुआ क्या है कि अगर आप देखें कि 1 से 2 साल लाइफ कम हो गई है, जो लाइफ एक्सपेक्टेंसी थी, ये वो ग्राफ शो कर रहा है। ये देखें कि लाइफ एक्सपेक्टेंसी फीमेल में और मेल की तो पहले ही कम थी फीमेल के मुकाबले में। हाँ, तो ख़वातीन जिंदा ज़्यादा रहती थीं। ये कोरोना ने ख़वातीन को भी कुछ नहीं कहा, मेल की ज़्यादा कम हुई है। अगली स्लाइड में दिखाऊंगा कि वो कितनी एक्सपेक्टेंसी कम हो गई है। अब ये देखें कि कितने परसेंट डाउन हो रहा है, और ऐसा ऐसा वक्त के साथ आपको पता चलेगा कि कोरोना ने हमारे साथ क्या किया है। यानी दिस वाज द एक सबसे बड़ा ड्रॉबैक ऐसा है। अब इसके साथ किया हमने क्या, कोविड जो है ना, उसने पाकिस्तान के अंदर तो अनफॉर्चुनेटली डाटा ही नहीं है, इसलिए हम कहते हैं कोरोना पाकिस्तान में फैला ही नहीं है। पाकिस्तान में डेथ रेट ही पूरी तरह रिपोर्टेड नहीं हुआ। हमने कहा पाकिस्तान में बंदे मरे ही काफ़ी हैं। एनी हो, ये ऐसा नहीं है। वो लोगों में छोटा सा छींक भी आ जाती है ना, कोविड टेस्ट कराते हैं, हमें बुखार भी आ जाए तो कहते हैं नहीं नहीं हमें तो कुछ भी नहीं है, हमें तो कोविड है ही नहीं है। दैट वाज द डायलेमा, दैट वाज द प्रॉब्लम कि आपके यहाँ हमारे यहाँ वो डाटा जो होना चाहिए। ये वेबसाइट है जिससे मैंने लिया कि फ़ीमेल को बीमारी तो ज़्यादा होती है लेकिन फ़ीमेल डेथ रेट फीमेल का एज़ कम्पेयर टू मेल कम था। एनी अब ये है कि 31 कंट्रीज़ के अंदर ये डाटा देखा गया है। सबसे ज़्यादा स्टडी अमेरिका में हुई और उसके बाद उन्होंने देखा कि कितने साल कम हो गई है। लेकिन ऐसा ऐसा ये होगा, हो सकता है कोरोना आया ही इसलिए हो कि बूढ़ों को इस दुनिया से जल्दी रुखसत करने के लिए। एनी नो डाउट इसके अंदर बूढ़े भी गए और नौजवान भी गए, ऐसे ऐसे लोग और बच्चे भी गए। एनी तो दिस वाज द अपडेट ऑफ द। अब क्या आया, वैक्सीन आई, मेरा ख्याल है पिछले साल वैक्सीन आई तो सबसे पहले चुगताई लैब में वैक्सीन आई तो मैंने सर को कॉल किया, सर वैक्सीन आई मैं लगवा लूँ। मैं इतने ये था वैक्सीन की अमाउंट कम थी, मैंने खुद नहीं लगाया, मैंने अपने बेटे को लगवाया। दैट वाज द। लेकिन एनी अब फिर जब ये वायरस आ गया है, इसकी म्यूटेशन हो गई है, तो हिस्टोपैथोलॉजिस्ट जो हैं उसको नो डाउट ज़रूर पढ़ते होंगे। लेकिन अब ये है कि सवाल ये है कि क्या ये वैक्सीन जो है ये काम कर रही है। देखें इसकी जो मौजूदा वैक्सीन है, जो मोनोवेलेंट वैक्सीन है, वो तो काम करना बहुत ही कम हो गई, उसकी वैक्सीनेशन वेनिंग हो रही है, लेकिन वैक्सीन की एफिकेसी कम हो गई है। लेकिन उसके बाद ये देखें कि उसकी उन्होंने क्या किया, ये पुरानी वैक्सीन जो थी वुहान वायरस के खिलाफ और डेल्टा वायरस के खिलाफ, उन्होंने फिर इसके बाद क्या किया, उसके साथ कुछ वैक्सीन के साथ एडजुवेंट लगाया और कुछ वैक्सीन के साथ उन्होंने ये किया कि उन्होंने 2 वैक्सीन मिला दी। अब वैक्सीन का खौफ था, बहुत ज़्यादा खौफ था, लोग लगवाते भी नहीं थे और ख़ासतौर वो सुई से ख़वातीन भी डरती थी, बच्चे भी डरते थे। उन्होंने बड़ा आसान काम किया, NIH ने भी इसके ऊपर काम किया और ग्रांट भी मिली है। ऐसा था कि पिछले 3 साल से क्योंकि एडमिनिस्ट्रेशन में हूँ तो मुझे कोविड के ऊपर ज़्यादा काम करना पड़ा, इसलिए मैं हिस्टोपैथोलॉजी का प्रेजेंटेशन से ज़्यादा, मैंने कहा बड़े बड़े हिस्टोपैथोलॉजिस्ट तो मौजूद हैं, लेकिन मैं कुछ आपको कोरोना के बारे में भी बता दूं। माइंड नहीं कीजिएगा कि मैं हिस्टोपैथोलॉजिस्ट हूँ और कोरोना के बारे में कुछ बता रहा हूँ। उसकी नेज़ल वैक्सीन के ऊपर वी आर आल्सो, कश्मीर में भी हम इस पर काम कर रहे हैं। NIH ने भी कुछ ग्रांट्स ऐसे किए हैं कि नेज़ल वैक्सीन जो है वो कितनी इफादियत होगी और उसके साथ ख़ास तौर पे वो खौफ और ख़त्म हो जाएगा। लेकिन नेज़ल वैक्सीन शॉर्ट लाइफ है, जल्दी उसकी वो ख़त्म हो जाती है, रिएक्शंस भी कम होते हैं। अब ऐसा ऐसा देखेंगे जिन लोगों ने 2 साल पहले mRNA लगवाया था उनके जॉइंट्स के अंदर छोटा थोड़ा पेन होना शुरू हो जाएगा, नॉट फॉर ऑल। लेकिन ऐसा है कि वैक्सीन के साथ जो एडजुवेंट लगाया जाता है वो कॉम्प्लिकेशन करता है, जिससे उन्होंने कहा कि ये जो वैक्सीन है इसके साथ वैक्सीन जो पुरानी वैक्सीन थी वो उसकी जो एंटीबॉडी बनाती थी उसका कुछ हिस्सा तो उसको साथ अटैच होता था, लेकिन कुछ हिस्सा जो है ये देखें कुछ हिस्सा, लेकिन ये कि सारी एंटीबॉडी जो है अगर स्पाइस के सर वाला हिस्सा S1 S2 को अटैच नहीं कर रहा तो उसके नीचे वाले हिस्से के खिलाफ भी वैक्सीन। इसलिए कहा जाता है कि नेचुरल इन्फेक्शन इज़ बेटर दैन द वैक्सीन, क्योंकि उसके अंदर और भी बहुत सारी एंटीजन होती हैं जिसके खिलाफ इंसान का एंटीबॉडी बनाया जाता है। हमने वो तो अभी देखा ही नहीं कि हमारे यहाँ जो बी लिम्फोसाइट के साथ टी लिम्फोसाइट को तो अभी देखा ही नहीं जाता। दैट इज़ वाई घबराने की कोई बात नहीं, इसलिए पाकिस्तानियों ने ना कभी मास्क लगाया है और ना कभी मास्क लगाएंगे। एनीओ मास्क का बड़ा फ़ायदा था, वो एक कम, क्योंकि मास्क ने ना सिर्फ कोविड को ख़त्म किया लेकिन इसके साथ दूसरी एलर्जी और पोलन एलर्जी को भी इन्होंने ख़त्म किया। अब ये जो अपडेट्स हैं इसके साथ जो मैं क्योंकि स्किप करूं, मॉडर्ना को और वैक्सीन को ये देखा कि उन्होंने जो कोरोना का BA.5 आया है इस और BA.4 का कंपोनेंट भी उसके अंदर डाला है और पुराना वो भी डाला है। अब ये बायोवेलेंट वैक्सीन है, इट इज़ मोर इफेक्टिव एज कंपेयर टू आवर प्रीवियस इफेक्टिव। जैसे वक्त के साथ साथ कोरोना के अंदर म्यूटेशन होती जा रही है, वैक्सीन की भी उस तरह अपडेट होती जाए। वैक्सीन का एक बड़ा ख्याल रखा जाए कि वैक्सीन की जो है डोज बहुत इंपॉर्टेंट होती है। वैक्सीन की कॉम्प्लिकेशन, ये जो मैंने जोड़ों का दर्द बताया है या इस तरह के मायोकार्डाइटिस है, पेरिकार्डाइटिस है, उसके टेम्परेचर के यूज़ के ऊपर हमारे यहाँ पाकिस्तान में अक्सर होता है कि वैक्सीन निकाली और बाहर पड़ी रही, तो उसके बाद उसका टेम्परेचर जैसे डाउन होता है तो उसकी कॉम्प्लिकेशन के बढ़ने के चांसेस भी बहुत ज़्यादा होता है। दैट इज़ वेरी इंपॉर्टेंट कि इन चीज़ों को हमें देखना चाहिए। वी शुड बी वेरी केयरफुल इन द यूज़ ऑफ टेम्परेचर इफेक्ट्स ऑन द जितना टेम्परेचर को हम कंट्रोल करेंगे वैक्सीन की एफिकेसी उससे उतनी बेहतर होगी। अब ये जो बूस्टर का प्लान है, किसी ने 1 बूस्टर लगवाया, किसी ने 2 बूस्टर लगवाया, किसी ने 3 बूस्टर लगवाया, किसी ने 4 बूस्टर लगवाया। बूस्टर ज़रूर लगवाएं और बूस्टर आपने लगवाते रहना है जब तक कि ये अगर पेंडेमिक ख़त्म हो गया तो जैसे मैंने कहा एंडेमिक, जैसे हमारे नज़ला की वैक्सीन, इन्फ्लुएंजा की वैक्सीन लगती है, कोविड की वैक्सीन भी आपको लगती रहेगी। बूस्टर की डेफिनेशन ये है कि लगवानी कब चाहिए, इतना टाइम, यानी ये नहीं है कि अब सवाल होता है कि क्या हम पहले बूस्टर लगवाएं तो दूसरी भी लगवाएं। अब पहले बूस्टर और दूसरे बूस्टर के अंदर अगर आपको टाइम पीरियड पूरा, यू कैन गेट द टाइम, तो टाइम पीरियड इज़ वेरी इंपॉर्टेंट इन दिस वन। लॉन्ग टर्म कोविड आया, उसके साथ कितनी कॉम्प्लिकेशंस हुई और एक वक्त आएगा कि आई थिंक आई एम वेटिंग दैट एनी पेपर कि कोरोना के अंदर किसी को स्क्वेमस सेल कार्सिनोमा हो गया, किसी को एडिनो कार्सिनोमा हो गया, क्योंकि किसी को लिम्फोमा हो गया, क्योंकि ये वहाँ रहता है। जिस तरह एक रेमिनेंट स्मॉल पीसेज ऑफ द बुलेट रह जाते हैं, ये भी उस तरह, दैट काजेज द लॉन्ग कोविड। लॉन्ग कोविड इज अनदर कॉम्प्लिकेशंस कि ये इसके बाद लॉन्ग कोविड के बाद मैं जस्ट स्किपिंग द स्लाइड, आपको लास्ट फ्यू स्लाइड पे लाता हूँ कि हमें करना क्या चाहिए, हमारी गवर्नमेंट को हमें करना क्या चाहिए कि ये, हाँ, साइकोलॉजिकल डिप्रेशन आप देखें कि पहले 25% था, अब 60 to 65 डिप्रेशन का शिकार हैं लोग। तो लोग पहले ज़माने में, पाकिस्तान में कहता हूँ, जब 2020 में लोग मरे तो दैट वाज ड्यू टू द खौफ, दैट वाज ड्यू टू पैनिक। दैट इज़ वाई अभी भी स्टिल द पीपल आर सफरिंग विद द पैनिक्स। अब ये एक रफ्सा रफ है कि अब इस डिप्रेशन को कैसे कम किया जाता है। काउंसलिंग इज़ वेरी इंपॉर्टेंट। और उसके बाद ये है कि अल्लाह पे तवक्का, गॉड इज़ एवरीथिंग, द लाइफ इज़ इन द हैंड ऑफ द गॉड, दिस इज़ वेरी इंपॉर्टेंट थिंग। नमाज पढ़ें, तहज्जुद करें, अल्लाह को याद करें, ये सारी चीज़ें आपको खौफ से ज़्यादा। फ्यूचर स्ट्रेटजीज इंपॉर्टेंट है सर। फ्यूचर इंपॉर्टेंट ये है कि गेटिंग एवरीवन लाइक अमेरिकन, अमेरिकन ने तो किया है, हम भी करें, पाकिस्तानी भी करें। विद द बेस्ट अवेलेबल प्रोटेक्शन थ्रू फ्री एंड ईजी एक्सेस टू न्यू अपडेट ऑफ द कोविड वैक्सीन। हमें कोविड वैक्सीन की अपडेट के बारे में पता होना चाहिए और पाकिस्तान को भी ये चाहिए कि वो सियासी दंगल से ज़्यादा कम आए, उससे बाहर आए, और उसके बाद जहाँ पे हमारा फ्लड रिलीव है उसके बाद ये वैक्सीन के बारे में काम करें। दैट इज़ वेरी इंपॉर्टेंट थिंग। सेकेंड, ऑफरिंग द न्यू अपडेट ऑफ द कोविड वैक्सीन फॉर फ्री 10,000 of the trusted locations with convenient appointments and the आज़ाद जम्मू कश्मीर को ये प्राउड हासिल है कि we first time started the vaccine in the students, 3rd year के 4th year का शुरू किया, फिर 2nd year। और मुजफ्फराबाद और मीरपुर, रावलाकोट एक ऐसी जगह है जहाँ पे फ्रीली हर किस्म की वैक्सीन, mRNA वैक्सीन और दूसरी वैक्सीन भी, एंड फोकसिंग ऑन द प्रोटेक्शन ऑफ दिस थ्रू द मोस्ट एट रिस्क, जो रिस्क पे पीपल हैं। इसके बाद एम्पावरिंग पीपल विद फैक्ट्स एंड आंसरिंग देयर क्वेश्चंस, स्पेशली द people should address with their own languages to the people. हमारे पाकिस्तान के अक्सर लोग जो हैं वो सराइकी बोलते हैं, उर्दू बोलते हैं, पंजाबी बोलते हैं. अगर हम उसको अंदर दूसरी लैंग्वेज में समझाएंगे, that is the very difficult. Testing treatment कि ensuring that everyone like Americans continue. मैं अमेरिका की इस मिसाल इसलिए दिया है कि ये सारी चीज़ें मैंने अमेरिका की वेबसाइट से लिया है कि that is why I also address my comment. मैं और किसी को तो नहीं कर सकता, लेकिन हम as a member of the task force, health task force, that these are the things that we should continue for this. This is my last slide. To keep communications, safe schooling and business and preparation of the new variants. कि नया वायरस आएगा तो उसके बारे में हमें किस तरीके से. Thank you once again. Thank you very much. And thank you very much, Professor Shahid Parvez. Thank you very much, Madam Naila Kiani. And thank you very much, my colleagues. And if you have any question, you can ask. Thank you so much.
Thank you, Dr. Mulazim. Our next speaker is an excellent histopathologist from Chughtai Institute of Pathology, Lahore. Please welcome Dr. Samira Zaman.
Bismillahirrahmanirrahim. Can I have my first slide? Okay. Okay. So my today's topic is regarding the Hirschsprung disease, which is seen in the infants and children. And do you know that there's some issue with the pointer? Okay, thank you. Do you know that there are around 100 million neurons in the gut, making it a second brain? That is why we frequently use the terms like gut feeling or butterflies in the stomach, which I am having right now. Can you please move from there, if it's possible, because I'm not... Hirschsprung disease is a congenital bowel disorder, and it is characterized by the absence of the ganglion cells in the myenteric and the submucosal plexus, with the prevalence of around 1 in 5,000, and it is slightly more common in males. Hirschsprung disease, although this is a benign disorder, can cause considerable morbidity, and this may be because of the underlying pathology, and it can be because of the multiple surgeries which these patients are likely to undergo. The aim of today's presentation is to improve the outcome of these patients by following some minimum data set that should be included in each biopsy report. On the left side is the normal gut with the normal distribution of the neurons, but on the left side you can see that on the right side, sorry, is the gut which is in red in color, is constricted, and this part of the gut lacks the ganglion cells. The upper dilated portion is normally ganglionic, and in between the aganglionic and the ganglionic segment is the transition zone. In order to identify or in order to diagnose this entity, we should have a very clear understanding of the enteric nervous system, and the one which is present between the two muscle layers of the muscularis propria is the back plexus or the myenteric plexus, and the submucosa have at two sites their collection of these ganglion cells are present. One is the immediately superior to its presence immediately superior to the muscle layer, and this is known as the Henle plexus. And the second distribution of the ganglion cell is present immediately beneath the submucosa, which is known as the immediately beneath the muscularis mucosae, which is known as the muscularis Meissner's plexus. Majority of these patients present by 6 months of the age, and they are characterized by, they present with the failure to pass meconium, they can have abdominal distension, Slightly older children, they usually present with a chronic constipation, and they can have a significant complications, the most dreaded one being the Hirschsprung-associated enterocolitis, having a very high mortality rate. The pathophysiology of the disease is not fully understood, and it is thought that the most common reason for this disorder is some disorder in the cell migration, which is seen during the embryonic life. And in 30% of the cases, the Hirschsprung disease is associated with congenital disorder. Coming on to the various types of the Hirschsprung disease, the most common is the short segment Hirschsprung disease, which is responsible for around 80% of the cases. In this case, the rectum and the distal part of the sigmoid colon is affected, and followed by the long segment Hirschsprung disease, in which the rectum, sigmoid colon, and the descending colon is involved. And the rest of the types of the ganglion of this Hirschsprung disease are extremely rare. And the most difficult one to diagnose is the ultra short, which has been recently described. There can be different modalities which can be used to diagnose this entity. The first one is the imaging techniques, which can diagnose Hirschsprung disease in up to 80% of the cases. Here the X-rays usually show the multiple fluid levels, and if the contrast media is used, they can even highlight the conus shape, which indicates the transition zone. But the pitfall or the limitation of this technique is that it cannot be done under 3 months of the age, because contrast media is administered to such children. Another characteristic of the Hirschsprung disease is the failure to relax the internal anal sphincter, and this again cannot be utilized in the children under 1 year of the age, because we know that this relaxed reflex develops after 1 year. And the most important diagnostic modality is the rectal biopsy, which can be diagnostic in up to 95% of the cases, and even up to 100% of the cases we can diagnose it if we use ancillary techniques and IAC, and if the patient or if the pathologist is well versed with the morphology and is experienced. We receive different types of the biopsies for the diagnosis of the Hirschsprung disease. The one which is mostly used is the suction biopsy, and it is used for the younger age group, and in this case it is easy to perform. It does not require any anesthesia, and the biopsy material contains mucosa and submucosa only, and therefore it is difficult to interpret such biopsies. The second most frequently received biopsies are the full thickness biopsies, in which all layers of the gut wall are present, but it requires general anesthesia, and it is associated with the serious surgical complications. And but the pathologists usually receive the generous amount of the tissue. Then there are other types of biopsy, like serosal muscularis biopsy, osteotomy, closure site biopsies. Even we receive frozen sections to look for the ganglion cells. In order to guarantee that the material which is removed from the patient and to increase the diagnostic yield of the biopsy, there are certain roles of the surgeons as well as certain responsibilities of the pathologist. The surgeon should make sure that he is taking adequate number of the biopsies, well above the anal verge, and that should be clearly indicated. The biopsy should be adequate size, and it should be of adequate depth. The biopsy should contain the submucosa, because unlike other GI biopsies, which we are looking at the mucosa, here the aim is to study the submucosa, to look for the ganglion cells. In addition, the surgeon should avoid micronodules, because in that case, frequently the lymphoid aggregates are present, which are likely to displace the ganglion cells. It is very important before giving a diagnosis of Hirschsprung disease that the biopsy should be adequate. How can we measure the adequacy? By whether the biopsy has been taken from the right side, right? And it should be, ideally, it should be 2 centimeters above the anal verge. And in ideal condition, surgeon should take at least 3 biopsies, 2 centimeters, 3 centimeters, and 4 centimeters above the anal verge. And these should be sent in the different container and labeling the exact distance. Another important thing is the thickness of the mucosa and muscularis mucosae should be equal to the thickness of the submucosa. But important thing to remember is once you have seen the ganglion cell, no matter what is the size of the biopsy, that is sufficient to rule out the Hirschsprung disease. Then there are certain roles to be done or certain responsibilities of the pathologist. The material which is received should be handled properly, and the pathologist should examine multiple levels up to 100 before giving a negative diagnosis. And the material and the pathologist should evaluate that material which is being submitted is of adequate nature and should have a clear understanding of Hirschsprung disease. The aim is to examine the multiple levels. For that, we need to have a multiple tissue levels in the single slide, and we can have up to 20 sections on single slide as well, making a ribbon of the tissue. The essential features of the Hirschsprung disease is the aganglionosis, that is the absence of the ganglion cells. There should be hypertrophy of the nerve fibers. This is a very diagnostic or helping sign that ganglion cells are likely to be absent. You can also use the ancillary techniques, that is the acetylcholine esterase activity, although we are not doing here, I'm sure in the Pakistan, but really this activity is increased in the Hirschsprung patients. And nowadays, IAC is a good alternative to the acetylcholine esterase, especially the chol-retinine, which is lost in the case of Hirschsprung disease. So coming to the normal or non-Hirschsprung disease morphology. So here you can see that the well-formed ganglion cells are present, and these ganglion cells have abundant cytoplasm, and the nuclei are eccentric, they are vesicular, they contain prominent nuclei, and roughly each ganglion within the two layers of the muscularis propria should contain 3 to 5 ganglion cells. Here's another picture showing a collection of the ganglion cells between the 2 layers of the muscle. This is the submucosa. And coming on to the high power, you can see there's a nice collection of the ganglion cell present immediately beneath the muscularis mucosae. Sometimes you find it very hard to look for the ganglion cells, especially if there's adjacent or if there's associated enterocolitis. This is a normal staining of the chol-retinine. Here you can see that there are nice staining of the neurites in the lamina propria, and there are thickened nerve bundles in the muscularis mucosae. This is where we are supposed to look for the chol-retinine staining. Instead of looking the staining in the submucosa or in the muscle layer, this is the area where the staining of the chol-retinine should be seen. That is within the lamina propria and in the muscularis mucosae. Now coming on to the Hirschsprung morphology. Here you can see the ganglion cells are absent. There are hypertrophied nerves in the submucosa, and these nerves are more than 40 micrometers in thickness. This is the Schwannian differentiation, which is present in between the 2 layers of the muscularis propria. Instead of the ganglion, there is the nerve or fibers, or you can call them as the fibers showing the Schwannian differentiation, and moreover, there are no ganglion cells are present here. And this is the collagen staining that is absent, completely absent. And this is the picture which I took from the net, in which you can see the ropey staining of the cells. That is the gain of acetylcholine activity in the case of the Hirschsprung disease. This is a transition zone. This is a very important. You should be familiar with the findings in the transition zone. That is, hypertrophic nerves are present in addition to the ganglion cells. So many times it causes confusion what to call it, whether it is a ganglionic or aganglionic. This is a morphology which is seen in the case of the transition zone. So while reporting, there should be you should remember that there are certain pitfalls. One is that the biopsy is taken from the lower level. That is the anorectal junction, in which you are able to see the stratified squamous epithelium. And if you see any island of stratified squamous epithelium, that is inadequate biopsy. Another thing is the presence of immature ganglion cells. These are a small collection of the ganglion cells present in the submucosa, especially in the premature babies. They are the cells, they are small in size, they lack cytoplasm. The nuclei are darker in staining, they lack nuclei, and with experience, only with experience, you are able to diagnose the presence of the of these immature ganglion cells. Sometimes mast cells, they do take the collagen staining, and they are normally present in the lamina propria, and that staining should not be taken as the positivity for the collagen. Another thing is the infection by the CMV, and CMV also causes the enlargement of the non-neuronal cells, mimicking the neuron cells. And so you should be familiar with all these pitfalls. We have already discussed this. Recently, the members of the American Pediatric Surgical Association we're having a special interest in the Hirschsprung disease, have a meeting with the pediatric pathologist, and they undergo group discussions. They have taken the review literature, and they have come up with some consensus guideline for the surgery and pathology reporting, and which was published in 2019 in the Journal of Pediatric Surgery. And they advise a synoptic reporting, just like the synoptic reporting which is adopted, which has been well adopted in the oncology pathology reporting. So just a last slide. Each biopsy report for the Hirschsprung should contain the type of the biopsy, the exact site of the biopsy, whether the biopsy is adequate or not, ganglion cells are present or not, hypertrophic nerves are seen or not, if as ancillary techniques are adopted, whether whether there's a gain or loss of these staining procedure, any significant diagnostic alterations, especially it is very important to report the enterocolitis and any comments which the pathologist is likely to convey to the surgeon. So coming on to the conclusion, pathologist has a very, very crucial role to make the diagnosis or to rule out the Hirschsprung disease. And it is very important to not to miss the diagnosis of Hirschsprung disease, because we know untreated Hirschsprung disease patients can have a very high mortality rate. And it is also not a good thing to overdiagnose the Hirschsprung disease, because in this case you are subjecting the patient to undue surgery. So it requires a close cooperation between the surgeon and pathologist, and adherence to the principles of reporting, which has been discussed earlier, is likely to improve the outcome of the patients with Hirschsprung disease. So these are some references, and thank you so much for your attention.
Thank you, Dr. Samina, for such an informative talk. Now I would like to invite chair and co-chair of the session to present souvenir to the speakers, please. Maybe in the end, or you want to do it right? Okay, fine. You summarize the session. Okay.
We come to the conclusion of this amazing session. There's some very good take-home messages. The job of histopathologist is becoming more and more exciting. You cannot, it's not that simple. I think you can hear me now, but so I'll be brief. We've lost quite some time. It's a very exciting session. The job of histopathologists is becoming more and more exciting. Carry home messages. It's not simple. Subtyping of tumors of all organs is gaining more and more importance. About cytology, good news for everyone is that, and with your permission, Dr. Shahid, that we are very close to starting second fellowship in cytopathology. This session has been exciting from many points of view. Dr. Mulazim Hussain has warned us that there are going to be even lesser males after COVID, and we can see the impact right now. Look at the stage, the presenters or the audience. It is massively dominated by females. So the effect is already there. Males need to be more careful now. Thank you very much, everybody.
Thank you, Dr. Shuktai. Now may I please request you to come on stage and present as, come here to present souvenir to the speakers. May I request Dr. Naveen Faridi to come on stage, please? Dr. Nadira Mamoon, please come on stage. Dr. Romana Idris, please come on stage. Dr. Qasim Ahmed, please come on stage. Dr. Saira Fatma, please come on stage. Dr. Mulazim Hussain, please come on stage. Dr. Samina Zaman, please come on stage. Now to present souvenirs to chair, co-chair, host and moderators, I would like to invite Major General Dr. Hafiz on stage. सर सबसे ऊपर रखिए. Dr. Farzana Memon. Dr. Sabah Hassan. Now to myself. Now I would like to invite Dr. Sabah Hassan on stage. Over to Dr. Sabah.
Thank you, Dr. Umia. It's now time for a short tea break of about 15 to 20 minutes. After that, there will be, of about 10 minutes, the general body meeting over here. So hopefully I'll see you all after the tea break over here. Please enjoy your tea. The tea break will be in the marquee.
PAP academic activities, I request the Professor Shahid Parvez, he will brief you regarding the activities of PAP conference.
Thank you. Thank you, Professor Ujjan. So, as Professor Ikram said that we took charge formally sometimes in March earlier this year. I and Professor Ikram, we traveled to Islamabad because besides documentation and things like that, the major thing is to become the signatory of the Pakistan Association of Pathologists, and for that now after FATF, you know, it's a big hassle all the time, you know, even to transfer the account to the other signatory. However, it was successfully done, and now any check which goes from Pakistan Association of Pathologists is signed by both of us with our stamps, which are now in the records of the National Bank of Pakistan, PIMS branch, where this account was originally opened. And obviously we were given, handed over the account with due audit by the ex-president Ashok Kumar with a very modest sum of money in there. However, and as we finish our term next year and we hand over to the next, you know, executive committee, president and secretary, we will again get this audited and then hand over. So now coming to this conference. So this conference in Karachi was held after a gap of, I think, about 10 years. And out of that, I think 2 years you have to exclude, which were gone in COVID world over. I think the last PAP conference was held, you know, when Professor Ali Hassan Zaidi, if you remember, it was a grand event held at College of Physicians and Surgeons, Pakistan. So after that, and we have seen unprecedented participation in this conference, so much so that all our estimates were gone wrong. Initially, we planned for 600. Then we thought, you know, we have to go to 800. But in reality, the total registrants were, I think, more than 1,250 or so. And that's why, you know, we, on behalf of the organizing committee, we apologize, you know, that many of those who, you know, suffered for various reasons, like, you know, long queues for tea, for food. Sometimes, you know, food is simply not there. The bags and those kind of things. Because at the last moment, you know, I mean, for the orbit and PC and, you know, all those, you know, there was a limit they could increase their capacity. So please forgive us for any unintentional, you know, lapses, and they are likely to happen, you know, so hope, you know, you don't mind it. But as far as the academic component is concerned, you know, I mean, the feedback which we got from all the societies is commendable, is very high, and you know, the quality of the papers, the participation, and so on, you know, I mean, it's unprecedented. You know, yesterday, Dr. Adnan Mustafa Zubairi, they concluded their session. There were several, I think, they said, you know, when the Major General Jafar Raza was there, Brigadier Amir was there, and all were saying that they don't remember such a vibrant conference, such actively participated, and the quality and foreign speakers, you know, in their recent memory. So that's all because of you and your participation. So I think this year we had 40 plus stalls. You know, the industry has been highly forthcoming, and without the help of the industry, this kind of you know, arrangement where 6 parallel sessions are going on would not have been possible. So they, under the severe economic crisis, and you know, they have been highly forthcoming, and we will, you know, pay our thank you to them, gratitude personally at the closing ceremony. So thank you those who became the life member. You know, we, for sake of promotion, we kept the fee to a minimum of 10,000, and we have 30 new members to whom we will be awarding the shields and the certificate. And from now on, as we decided that the life membership fee will be 20,000, right? Now, as far as the PAP academic activities are planned, I will refer back to next year, refer back to the Secretary PAP.
Inshallah, we have planned 4 mini conferences, workshop and conference in different cities of Pakistan. And after the 4 mini conferences, then we arrange one big conference on the platform of PAP in Lahore, inshallah, next year in November 15th.
Yeah, that's correct. And that was actually decided in the executive committee meeting, which was held at Chukta Institute of Pathology. And all of us participated in that. And what happened actually, I think the Mulazim couldn't come, but the secretary, the next elected secretary who's from army, she was there, Ashok and all those were there. And there we decided to hold this conference in Lahore. But then as soon as this message went out, we came to know that only with a difference of 1 week, the ChemCon, the Pakistan Society of Chemical Pathology meeting, is already arranged very well in advance with several foreign speakers already committed in Karachi. So for industry and for everyone, it was not possible that, you know, for a 1 week difference, you know, all this big equipment, they bring it here, they take it to Lahore and all that. So they all came to us, to me, and persuaded me that if we can combine this, which I did, and I think thankfully, probably it was a very good decision, and I think that's why, you know, all these societies came together in a big way, which not happened in the past. And so we swapped it. So this was actually, that decision was taken. So next year, the dates we already announced, and we will take your acceptance and endorsement for that the next PAP conference and societies of the pathology will be held in Lahore, 17, 18, 19 November, because you know, this is a very busy time, and even they have to book, I think probably they have already booked the Pearl Continental in Lahore, because that's a very busy time. And also engage our international speakers, you know. So that's one thing about the conference, sir.
So anything,
Sir, इसमें एक आध एजेंडा पॉइंट देखिएगा मेरे पास है अच्छा हाँ इसमें हाँ जो ओके ऑल राइट सो ये सारे पॉइंट्स प्लीज़ आप लोगों से गुजारिश है कि इसको एंडोर्स कर दें कोई एंड कोई सेकंड भी कर दें थैंक यू
वेरी मच
तो इसकी मिनट्स वगैरह हम जो है
we will write the minutes and circulate along with the audit copy of the all expenses.
जी अच्छा इसके अलावा बस अब इसके बाद हमारा लास्ट सेशन अब शुरू होने वाला है और फाइनली तो खैर मैं सिर्फ 1-2 मिनट के लिए पहले प्रोफेसर आली हसन जैदी साहब से कहूँगा कि जैसे उन्होंने बता रहे थे कि जो फाउंडर मेंबर्स में से सिर्फ 2 हैं माशाल्लाह एंड दे आर वेरी एक्सट्रीमली प्रेशियस फॉर अस एक प्रोफेसर आली हसन जैदी साहब हैं और दूसरे हमारे सिंध लैब के जो हैं ख्वाजा इफ्तिखार साहब हैं। तो इनको फिर मैं दावत दूंगा। तो बस ये है कि माशाल्लाह अब यहाँ पर हम प्राइजेस देंगे, पोस्टर्स के प्राइजेस हैं, ओरल प्रेजेंटेशन के हैं, कुछ तो जो हमने ऑलरेडी अनाउंस किए हैं सारे सोसाइटीज़ के आइडेंटिकल प्राइजेस हैं। 1 फॉर बेस्ट ओरल फॉर ट्रेनी एंड 3 फॉर बेस्ट पोस्टर्स फर्स्ट सेकंड थर्ड फॉर ट्रेनीज़, जो कि तमाम सोसाइटीज़ में किए पैप की तरफ से हैं। इसके अलावा ओवर एंड अबव जो है वो हमारे पुराने जो साथी हैं मैक्सिम वाले, उन्होंने 4 फर्दर प्राइजेस हमें दिए हैं, स्पेशल प्राइजेस, एक ओरल के लिए और 3 पोस्टर्स के लिए। वो हम ओवर एंड अबव देंगे और उसके लिए ट्रेनी होना ज़रूरी नहीं है। जो भी एवेल्यूएशंस हमारे जैसे पोस्टर्स की एवेल्यूएशन हमारे जो बाहर से शफीक गिल और मरियम आए हुए हैं उन्होंने की हैं, इसी तरह अभी जो नेक्स्ट सेशन होगा उसमें जो यहाँ पर एक्सपर्ट्स हैं वो जो सिर्फ ट्रेनीज़ की उसकी एवेल्यूएशन करेंगे, तो उस पर हम प्राइजेस वगैरह देंगे। तो और इसके अलावा एक बुखारी गोल्ड मेडल, जो कि बहुत अरसे से ये चीज़ सस्पेंड हो गई थी। इट्स ए दिस इज़ समथिंग जो कि हमेशा से चली आ रही है। आई स्टिल केप्ट माई बुखारी गोल्ड मेडल एंड यू नो व्हेनेवर आई लुक एट इट आई हैव ए फीलिंग ऑफ ग्रेटिट्यूड एंड सेटिस्फेक्शन। तो वो भी है, लेकिन चूँकि अब 6 सोसाइटीज़ हैं तो ऐसा है कि सबसे नॉमिनेशन हम ले रहे हैं और उसके बाद एक लॉटरी हो जाएगी तो एक को मिल जाएगा, बाकियों को सर्टिफिकेट मिल जाएगा कि दे क्वालिफाइड फ्रॉम दैट। तो उनको एक्चुअली नहीं मिलेगा क्योंकि ज़ाहिर है देयर आर लिमिटेशंस। तो आई थिंक विद दैट अदनान ज़ुबैरी साहब ज़रा प्लीज़ आप भी कुछ कह दीजिए, उसके बाद फिर हम
आज मेरी खुशियों की कोई इंतहा नहीं है और इसके पीछे कुछ अवामिल हैं, कुछ यादें हैं जो मैं चाहूँगा कि आपके साथ शेयर करूँ फॉर ए फ्यू मिनट्स। सबसे पहली बात तो ये आज जनरल बॉडी हो रही है, बड़ा खुश आइंद मौका है और मैं देख रहा हूँ कि आज की इस महफिल में हमारे अटेंडेंट जो है बहुत काफ़ी हैं, जो एक बहुत ही अच्छी अलामत है। इससे पहले ऐसा कम देखने में आया है। मैं चाहूँगा कि थोड़ी सी बातें मैं पिछड़ी कर लूँ, बहुत मुख्तसर। PAP की तारीख बहुत लंबी है, बहुत अच्छी है और बहुत यादगार है। इस पर जिस तरह से आहिस्ता 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 तरक्की हो रही है उसका मैं चश्मदीद बहयात गवाह हूँ। मेरे साथ एक गवाह और है जो हयात में है और वह है प्रोफेसर इफ्तिखार साहब, इफ्तिखार ख्वाजा। उसके बाद जो सिलसिला चला वो बहुत ही खुशाइन था, बहुत पुरउम्मीद था और हमारे जितने फाउंडर्स थे उन्होंने इतनी तको-दो इतनी मेहनत के साथ यहाँ तक पहुँचाया। मुझे याद है कि जब मैं प्रेसिडेंट बनने से पहले एक बार मैंने इलेक्शन लड़ा और मैं नाकाम हुआ, मगर मेरी ख्वाहिश थी मैं फिर इलेक्शन लड़ूँ। मैंने फिर इलेक्शन लड़िया और मैं जीत गया। उसके बाद मुझे कुछ ऐसा लगा और मैंने सुना भी अपने कान से लाहौर में, ये पैप अब बंद हो गई है, ख़त्म हो गई है। खुदा का शुक्र है मैंने उसी में कहा कि नहीं, अब पैप का इब्तिदा हुई है दोबारा। और जब मैंने पहली बार अपने दोस्त, अजीज़ दोस्त को, सोहेल चुगताई साहब को जहन में लाया कि आइंदा से इंशाअल्लाह ताला ये बनेंगे प्रेसिडेंट, उनको मैंने चुना, उन्होंने सेलेक्ट किया और उनको कन्विंस किया कि वो आए हमको ज्वाइन कर, और माशाल्लाह उन्होंने ज्वाइन किया और बहुत शानदार काम किया। उसके बाद मेरा यकीन और पुख्ता हो गया और मैंने कहा आइंदा के लिए जो लोग आए सब काम करेंगे, सब अच्छा काम करेंगे, लेकिन आइंदा के लिए लोग जो आए उसमें एक ऐसा नाम भी होना चाहिए जो वाकई पैप को आगे बढ़ाए। और वो थे हमारे दोस्त शाहिद परवेज़। जिस वक्त मैंने उनको चुना, मैंने कहा ये शख्स वो शख्स है जिसने वो काम किए जो अब तक हमने नहीं कर पाए। हम बुजुर्गों ने, हम सफ़ेद बाल वालों ने नहीं किया। इन्होंने जो कंट्रीब्यूशन किया वो आज भी हमारे लिए काबिल तक़लीद है। इन्होंने माशाल्लाह हमारे साथ रखे 1935 कॉन्फ्रेंस जो की CPSP में, वो भी एक यादगार है। उसमें ये पेश थे। ये सिलसिला चलता रहा, कुछ गैप्स आए, मगर फिर भी आज हम देख रहे हैं ये कॉन्फ्रेंस, ये जनरल बॉडी उससे ज़्यादा मुस्तहकम हो गई है जो हमारे दौर में थी शायद। और इसकी वजह इसके सामने हमारे मौजूदा सदर जनाब परवेज़ साहब और उनके साथी जनरल सेक्रेटरी इकराम उज्जैन साहब, और हमारे सेक्रेटरी कमेटी अदनान जुबैर साहब, और इमीडिएट पास्ट प्रेसिडेंट मुलाजिम साहब, ये वो लोग हैं जिन्होंने आज हमारी पैप को मुस्तहकम किया है, जिनसे उम्मीद है कि आइंदा भी ये पैप हमारे नौजवान पैथोलॉजिस्टों को, यंगर जो पीढ़ीज हैं, इनको लेके आगे बढ़ेंगे और इसको और आगे बढ़ाएंगे। मेरी ख्वाहिश है, मेरी उम्मीद है कि हम इसके साथ साथ हमारा जो मैनिफेस्टो या हमारा जो कॉन्स्टिट्यूशन पैप है उसको हम अक्सर बेशतर देखते रहे, ताकि हमारी जो मजबूती और होगी। मैं ज़्यादा नहीं लूँगा क्योंकि वफात बहुत कम है और आइंदा सेशन शुरू होने वाला है। मैं इन तमाम बातों के साथ आप तमाम का बहुत शुक्रगुजार हूँ, खासतौर से शाहिद परवेज साहब का, इदनान साहब का और हमारे उज्जवल साहब का, और हमारे इमीडिएट प्रेसिडेंट इलेक्ट का, इनके हाथों अब तलवार जाएगी, हैंड ओवर जाएगा, वो इनको भी इंशाअल्लाह ताला ऐसे ही करना पड़ेगा। मुझे उम्मीद है कि हमारे दरमियान एका रहेगा, हम सब मुत्तहिद रहेंगे, और हमारी जो सोसाइटीज हैं दे आर ए पार्ट एंड पार्सल ऑफ PAP। पहले इमरजेंसी की सोसाइटी एक और सोसाइटी नहीं थी, सिर्फ पैप थी और सब इसके मेंबर थे। और प्रोफेसर N.A. जाफरी मरहूम ने, खुदा उनकी मग़फ़िरत करे, उन्होंने ख्वाहिश जाहिर की थी कि काश सब मिल जाएं, और ये हुआ। हम लोग सब मिले हुए हैं और हम आइंदा भी मिले रहेंगे। इनके साथ मैं आपका बहुत मशकूर हूँ, बहुत शुक्रगुजार हूँ कि आज की कॉन्फ्रेंस भी उन्हीं अच्छी कॉन्फ्रेंसेस में है जो हमने पहले देखी है। बहुत बहुत शुक्रिया। थैंक यू वेरी मच।
Sir, thank you very much. Now we will start the next session.
जी, बिस्मिल्लाहिर्रहमानिर्रहीम। थैंक यू वेरी मच प्रोफेसर शाहिद परवेज़। शाहिद परवेज़ ना सिर्फ प्रेसिडेंट हैं, मेरे उस्ताद भी हैं। I came from King Edward Medical University when I was getting the training of FCPS Part 2, और उसके साथ डॉक्टर नायला कियानी भी है। तो highly obliged always, sir, you are behind me. Whatever I am here, I think this is the blessing of my teachers. एक बात, दूसरी सर एक चीज़ एनी हाउ कि दिस वाज वेरी इंपॉर्टेंट थिंग दैट जो आपने इतने बड़े लोगों को बुलाया, और उसके साथ जो आपने अच्छी चीज़ें की इंशाअल्लाह ताला। आपके इसके चुगताई साहब भी हैं, मेरे ख्याल में बैठे होंगे इंशाअल्लाह ताला, कि उनके साथ भी हमारे वो उस्ताद भी हैं और हमारे एक रहनुमा भी हैं। जो फ्यूचर प्लानिंग होती है ना सर, जो कल आप बता रहे थे ना सर कि क्या फ्यूचर था, किस तरीके से हम पैथोलॉजिस्ट को ले आए थे और किस तरीके से हम वो आगे जा रहे हैं। आई एम आल्सो मेंबर ऑफ टास्क फॉर हेल्थ टास्क फोर्स फेडरल गवर्नमेंट, and also from Kashmir I am also member of the PMDC. तो let's see कि हमें जो है एक चीज़ जो है, नो डाउट सर मेरी गुजारिश ये होगी, आप इसको नाराज़ ना हों, कि नो डाउट अब FCPS का ज़माना आ गया है, लेकिन हमारे बहुत सारे लोग जो थे हमें हमारे प्लेटफॉर्म पे ये कहते थे कि जनाब हमारे MPhil जो किए हुए हैं हमारा क्या बनेगा। ये पैप एक ऐसा एम्ब्रेला है सर कि जो आपके साथ मिल के उनको एक कैप दें, रास्ता दें और उनकी प्रोटेक्शन सॉरी ये अच्छा। इसके बाद ये है कि आई एम हैप्पी कि मैंने इस स्टेज को कहा कि इस लेवल पे कहा कि हमने FCPS Part 2 वालों को सर गुजारिश की, और मेरी ये गुजारिश के ऊपर उन्होंने 2 साल काम करके इंटरमीडिएट करके जितने भी लोग MPhil किए हुए किसी भी स्पेशलिटी के अंदर जो था वो दे डू द FCPS। नो डाउट आवर फ्यूचर इज FCPS, लेकिन इन MPhil और वो उसके बाद सेकंड थिंग इज़ कि हमें पैप के लेवल के ऊपर जो है ना सर, इस चीज़ को एक ऐसी एक माशाल्लाह जन साहब भी बैठे हैं, बड़े अच्छे लेवल पे बैठे हैं, आप भी बैठे हैं, हम एक ऐसी कमेटी बना सकते हैं कि जो हमारी ट्रेनिंग जो है उस ट्रेनिंग को हमारे स्क्रूटनाइज करें और रेगुलराइज करें कि किस तरीके से कहाँ होती है क्या नहीं होती। क्योंकि हमारे पुराने टीचर सर सारे के सारे MPhil हुआ करते थे। फिर एक PhD का मसला आया सर, PhD नो डाउट मैं लोगों को इसका कंसेप्ट सर नहीं है, आप भी PhD हैं सर और मैंने भी PhD की, आई डिड इट आफ्टर FCPS। तो ये है कि उसके साथ हम इसको भी मेरा ख्याल है कि उसमें नम्स में बैठे हैं, मेरे जनरल साहब बैठे हैं, मेरे जनरल ताहिर के साथ मिलके एक जो करिकुलम हमने बनाया था, अगर उसको अडॉप्ट कर लिया जाए, मेरा ख्याल है कि उसमें एक डॉक्टर राबिया है, ही डिड द PhD। और जिन जगहों पे सर आप देखें कि पैप एक ऐसा एक्टिवली इन्वॉल्व रोल अदा करे कि उसको एक मॉनिटर करे कि किस तरीके से हमारी मॉनिटर हो रही है। सेम है सर उन जगहों पे जहाँ मैं मुजफ्फराबाद मिसाल तौर पे बैठा हूँ सर, कि मैं आई वांटेड टू स्टार्ट द FCPS Part 2 इन हिस्टोपैथोलॉजी, मेरे पास वो नहीं होता कि तो इस तरीके सर पैप शुड प्ले सर वेरी इंपॉर्टेंट रोल। जैसे आपने मुझे 2 माह 3 माह के लिए KEMU से बुलाया, यहाँ पे बुलाया, तो मैं माई सेल्फ एट दैट टाइम आई थिंक 20 ईयर बैक जब मैं रोटेशन, तो इस तरह की सर हमें जो फ्यूचर के अंदर नो डाउट आई एम योर प्रोडक्ट, कोई कहेगा ना मैं कौन हूँ, मैं एम योर प्रोडक्ट, तो ऐसा होगा कि हमें इन चीज़ों के ऊपर ज़्यादा जोर देना चाहिए कि हमें उन जगहों पे जहाँ पे ट्रेनिंग के फ्लाज हैं सर उसको देखें। आपका रोल ख़त्म नहीं होता सर, इंशाल्लाह ना होगा, आप सीनियर टीचर्स हैं। तो इसमें यह है कि मेरी PMDC से वालों ने ये बात मानी है कि वट एवर द पीपल हैव डन ऑलरेडी MPhil एंड दे वर रजिस्टर्ड, दे विल बी अगेन रजिस्टर्ड, नो डाउट इसके साथ। और दे वर नॉट, नागी साहब को अल्लाह उम्र दराज करे, एक ज़माने में कहा करते थे कि द पैथोलॉजी इज़ ए क्लिनिकल सब्जेक्ट, और उस क्लिनिकल सब्जेक्ट के ऊपर हमने इसको पिछले साल में कहा यू प्लेड ए वेरी गुड रोल। फिर एक गैप आया और 20 से 25 साल तक हम इसको सफ़र करते रहे, लेकिन हमने पिछले से पिछले साल इसको वो कराया, उसमें चुगताई साहब का रोल बहुत ज़्यादा है कि हर उसके अंदर हमारे साथ खड़े होते हैं। तो वही ये आपको भी हैप्पी नॉ पैथोलॉजी इज़ ए क्लिनिकल सब्जेक्ट। अब PhD को रजिस्टर ना करने का मसला था, वो भी हमने उसको काफ़ी हद तक उसको हल कर दे। दैट इज़ वाई ये मेरी गुजारिशात होंगी इंशाल्लाह सर। नेक्स्ट जब इंशाल्लाह, अभी तो आपका 1 साल है ना सर, जब इंशाल्लाह चलेगा तो हमें ये नहीं है कि साल के साल आएँ और देखें कि हम क्या कर रहे हैं, इसको ज़्यादा इफ़ेक्टिवली देखें कि हमारे जो PGRs हैं, जो बच्चे हैं हमारे, वो हमसे किस तरह की तवक्को रखते हैं। और इंशाल्लाह सर मैं जैसे ही होगा इंशाल्लाह मैं भी आपके साथ आपकी मशावरत में आपको रखूँगा। और एक दफ़ा वंस अगेन कांग्रेचुलेशन प्रोफेसर शाहिद परवेज़ एंड योर टीम एंड यूर फॉर कंडक्ट वेरी ब्यूटीफुल और बहुत ज़्यादा मुनज़्ज़म तरीके से, और इतनी बड़ी तादाद में कोविड के बाद सर 3 साल के बाद ये हुई जो फैसलाबाद में होती है। इंशाल्लाह बढ़ते रहें यूँ ही कदम हया अला खैरुल अमल, हमें आगे बढ़ना है इंशाल्लाह। थैंक यू सो मच सर।
थैंक यू। आई थिंक कि हम चूँकि नेक्स्ट सेशन, लेकिन हमारे पास्ट प्रेसिडेंट आ गए हैं, तो एक क्विकली ज़रा प्लीज़ इसको ज़रा क्लोजिंग रिमार्क्स दे दीजिए और फिर हम लास्ट सेशन की तरफ जाते हैं और फिर क्लोजिंग सेरेमनी।
थैंक यू वेरी मच प्रोफेसर शाहिद परवेज़, मतलब प्रेसिडेंट PAP एंड प्रोफेसर इकरामुद्दीन उज्जैन सेक्रेटरी PAP एंड फ्यूचर प्रेसिडेंट मतलब प्रोफेसर मुलाजिम हुसैन बुखारी जैदी साहब एंड ऑनरेबल मतलब कलीग्स, अस्सलाम वालेकुम। पास्ट आपको पता है कि PAP का मैं प्रेसिडेंट था, और जो भी हमसे अल्लाह ताला ने तौफीक दी थी, जो भी काम करवाया, रियली मतलब PAP इज़ इन द राइट डायरेक्शन एज फार एज आई थिंक। मतलब काफ़ी हमने डेटा सारा मतलब आप लोगों का पैथोलॉजी जितने भी मेम्बर्स हैं सबको मतलब अल्फ़ाबेटिकली मतलब कि अब आपका डेटा मतलब जो कि मुझे याद है 2009 के बाद ये अपडेट नहीं हुआ, लेकिन ये अब आपका डेटा सारा अपडेटेड है। और आपकी मतलब वेबसाइट भी है, उसको मैं प्रोफेसर शाहिद परवेज़ को भी रिक्वेस्ट करूँगा, ये चुगताई साहब की बहुत मेहरबानी है हमारे ऊपर PAP के ऊपर कि उन्होंने मतलब वो हमें दिया हुआ है मतलब कि हम उसको यूज़ कर सकते हैं। तो मैंने उसको काफ़ी यूज़ किया मतलब 2 साल जो मेरा टेन्योर था। तो प्रोफेसर शाहिद परवेज़ आई थिंक मतलब ही विल कंटिन्यू द सेम थिंग्स। और दूसरा मोबाइल ऐप आपका बना हुआ है ये PAP का, तो प्लीज़ उसको आप सब लोग यूज़ करें। मतलब जहाँ जहाँ आपका प्रॉब्लम्स होते हैं, इकरामुद्दीन उज्जैन साहब हैं, प्रोफेसर शाहिद परवेज़ हैं, हम लोग हैं आपके साथ, तो आप उसको यूज़ करें। मतलब आजकल वक्त के साथ ये डिजिटलाइजेशन का दौर आ रहा है, जो आपने अभी देखा, AI मतलब वो आगे वक्त के साथ फ्यूचर है हमारा, तो इन चीज़ों को यूज़ करें प्लीज़। मतलब दीज थिंग्स आर फॉर यू पीपल, यंगस्टर्स, तो इनको यूज़ करें। और पैथोलॉजी इस वक्त मैं फील कर रहा हूँ कि काफ़ी एक्टिव आपका फोरम है, लेकिन जब तक कम्युनिकेशन नहीं होगी ना तो फिर प्रॉब्लम्स हमारे सॉर्ट आउट नहीं होंगे। तो मुझे कुछ लोगों ने शिकायत है कि छोटी मोटी, मैंने कहा यार किसी की नीयत में नहीं होता ये कि मतलब वो कोई इस तरीके की चीज़ करे, लेकिन उसके नॉलेज में नहीं होता, बिकॉज ही हैज़ टू डू सो मेनी अदर थिंग्स in addition to मतलब whatever you are saying। तो प्लीज़ मतलब कम्युनिकेट द थिंग्स विथ ईच अदर, और हर किसी को पॉजिटिव लें और हर किसी की रेस्पेक्ट करें और चीज़ों को अंडरस्टैंड करें कि वी आर फॉर बेटरमेंट, किसी का भी पर्पज़ नहीं है। करंट जो लोग बैठे हुए हैं PAP के जो एग्जीक्यूटिव काउंसिल मेंबर है, फ्यूचर में प्रोफेसर मुलाजिम हुसैन बुखारी प्रेसिडेंट इलेक्ट, और उनके साथ भी जो टीम आएगी, आई एम ऑप्टिमिस्ट एंड श्योर मतलब दे विल बी हेल्पफुल एंड डू द बेस्ट थिंग्स फॉर द PAP मतलब। तो हमने मिलजुल के चलना है और PAP को पॉजिटिव डायरेक्शन में आगे लेके जाना है। बाकी और भी काफ़ी चीज़ें हैं, लेकिन वी आर वर्किंग ऑन इट। जैसे हमारे यंगस्टर्स के कुछ चीज़ें, उनकी ट्रेनिंग के इशूज़ हैं, उसमें भी हम काम कर रहे हैं। PAP के कॉन्स्टिट्यूशन में चेंजेस लानी है, वो भी हम काम कर रहे हैं। तो इंशाल्लाह एक दिन आप देखेंगे PAP विल बी एक्चुअल मदर ऑफ द ऑल द मतलब जो इसकी सब स्पेशलिटीज़ हैं, हिस्टोपैथोलॉजी, माइक्रोबायोलॉजी, मॉलिक्यूलर बायोलॉजी और जो भी इम्यूनोलॉजी, तो वी आर फॉर द बेटरमेंट. तो आप हमें से, हम आप में से, प्लीज़ कम्युनिकेट द थिंग्स, मतलब वॉट एवर इज इन अवर hands and whatever is possible, definitely we will do by core of heart. And thank you very much, Professor Shahid Parvez and Professor Ikramuddin for arranging such a nice conference. Thank you.
Thank you very much, sir. And thank you all three presidents and all the members of Pakistan Institute of Pathology. So we, sir, kar diya, inshallah. So we will start the next session, inshallah. Assalamu alaikum.
Assalamu alaikum. My name is Dr. Asad and I am a consultant at Liaquat National Hospital and Khan University Hospital. Just to speed things up, the next session is on free papers and the oral presentations, and the moderator for this session will be Dr. Kurat. I would like to invite Dr. Kurat to start this session off. Thank you.
Thank you, Dr. Asad. Assalamu alaikum and welcome back. So now we begin the last session for today and for the conference, which is free paper oral presentation, which will be followed by a question and answer session. To judge and score the papers, I would like to call on stage the chair of this session, Dr. Talat Mirza. Please welcome Dr. Talat. And our co-chair for the session is Dr. Mariam Musa. We have 8 presenters today. Each of you will be having 8 minutes of time, and I request you all to please be mindful of your allotted time limits. So the first presenter with us is Dr. Asma Khattak.
Assalamu alaikum. Assalamu alaikum. I'm Dr. Asma Khattak from PIMS Histopathology Department, and I'm here to give the brief account of the research work which we conducted in our setup. It was regarding evaluation of mismatched repair genes, free deficiency in endometrial cancers using immunohistochemistry. Just to give a brief concept what we did, we all know that the DNA has very regular nucleotide sequence which are located along their entire length, and they are always tightly, their number is tightly regulated. Whenever there will be increase in the nucleotide sequence which is abnormal for that focus, it leads to microsatellite instability. This instability has to be corrected, because if it's not corrected, it will move from one cell cycle to the next, and it will result in tumorigenesis. Nature has provided us with certain proteins which are 4 in number and they occur in pairs for repairing that unstable foci. But sometimes it happens that these proteins are themselves mutant and therefore they are functionless. And this leads to the formation of mismatched, repaired, deficient endometrioid adenocarcinomas. This is the overview of my presentation. Endometrial adenocarcinoma arises from the inner lining of the endometrial cavity, and it's the sixth most common cancer worldwide. In USA, it is the leading cancer in female. About 65,950 cases are reported in 2022. In the UK, it's the most common cancers, and about 9,700 cases reported annually. And in Pakistan, it stands third among gynecological cancers, that is 4.3%. These are the risk factors, which includes obesity, and it includes nulliparity, and as well as, I can't see the things, and prolonged use of tamoxifen, and it can be associated with other cancers such as colon, endometrial, and gastric carcinomas. And if this association occurs, it means that there is high chance, frequency, or possibility of genetic predisposition. Traditionally, we classify endometrial carcinomas into type 1 and type 2. Type 1 endometrial carcinomas are low grade, and they are of favorable prognosis. They show favorable prognosis, and they are strongly ER and PR positive. Type 2 endometrial carcinomas are high-grade endometrioid, serous, and clear cell carcinomas. They have poor prognosis because they are high-grade tumors with a propensity for distant metastasis. This classification is generally used in clinical scenarios, but it has a limited application now because it is based on histopathological assessment and grading, and because of that, it is highly subjective. To overcome that, a newer classification, which was molecular, was proposed by TCGA in 2013. And according to this, endometrial carcinomas, they have 4 subtypes. And it's more useful classification because it defines the underlying molecular abnormalities, and therefore it reflects the tumor biology. And at the same time, it can also predict the therapeutic response to therapy, because now it is in the form of immunomodulators, which is now available for endometrioid carcinomas, which are MMR deficient. The aim of our study was to identify endometrial cancers with MMR protein deficiency by IHC and to evaluate the clinicopathological features, as well as to assess the percentage of tumors that could benefit from the immunotherapy. It was a cross-sectional study, and a consecutive method of sampling was applied to 80 cases of endometrioid adenocarcinomas, which included small biopsies and hysterectomy specimens. IC was applied for all 4 markers, that is MLH1, PMS2, MSH6, and MSH4. These are the methods. According to CAP guidelines, complete absence of any one of the 4 MMR proteins was interpreted as loss of expression and therefore MMR deficient. And this loss of expression was divided into 4 groups: isolated loss of MLH1, combined loss of MSH2, MSH6, and MLH1, PMS1 respectively, and loss of expression of all 4 markers. We included all cases of endometrioid carcinoma, and all cases of high-grade tumor types and other tumor types were excluded from our study. Coming to the results, among 80 cases, almost 12.5% of the tumors, they showed isolated loss of MLH1, whereas combined loss for MLH1 and PMS2, MSH6, and MSH2 were seen for 2 cases each, that is 2.5% respectively, and 4 cases of that is 5% of the total, which showed entire loss or immunonegativity for all the 4 markers. Among MMR deficient tumors, most of the tumors, they fall in to FIGO grade 1 and 2, that is 83.3%, and whereas FIGO grade tumors 3 tumors were only 16.67%. As far as staging is concerned, the MMR deficient tumors were equal in number for stage 1 and stage 2, that is 20%, whereas none was seen, no MMR deficiency was seen in stage 3 tumors. This photomicrograph shows loss of immune expression for MLH1 and PMS2 in A and B, and whereas it's in D&E there's intact expression for MSH2 and MSH6. And this is again another case of grade 2 endometrioid adenocarcinoma with loss of expression for MSH2 and MSH6, and whereas intact expression for MLH1 and PMS2. And this is another case of grade 3 endometrioid adenocarcinomas in which we can see that all 4 proteins are, immune expression is negative. Coming to discussion, we found that about 22.5% of the cases were MMR deficient, and therefore it is in conjunction with a study which is conducted by Dogri et al. And Juman et al. And FIGO grade 1 tumors was highest, that is 83.3%, and this was also in conjunction with a study conducted by Dogri and et al. But contrary to McKean, who observed highest number of cases in FIGO grade 3, isolated loss of MLH1 was seen in 12.5%, and similar observation was made by Dogri et al. And Sharma et al. And the combined loss for MSH2 and MSH6, as well as MLH1 and PMS2, was 2% each. This was confirmed by Jane et al. And but the discrepancy for MSH2 and MSH6, which was seen, this slight discrepancy may be due to larger sample size. We come to the conclusion that MFR deficient endometrioid adenocarcinoma is frequent in our setup, and IC is easily available, it's cost effective and robust method for identification of these tumors. And it's moreover, as targeted therapy in the form of immunomodulators is available, it is now recommended for MMR deficient tumors. It will help the oncologist in management plans. Recommendations are that universal testing for MMR proteins should be done on routine practice, as also it is recommended by National Comprehensive Cancer Network. Patient diagnosed with endometrial cancer in small setups should be referred to laboratories where facilities for IC are available. And furthermore, molecular testing can be performed to confirm MLH1 status, promoter methylation status, and to exclude genetic mutations. Limitations were small sample size and unavailability of sequencing facility, lack of follow-up of the patient, and unavailability of the family history. These are the references. Thank you.
Thank you, Dr. Asma. I request again all the presenters, please try to limit your presentations to 8 minutes because we are already running short of time. So our next presenter is Dr. Muhammad Umair Khan.
Does it work or? What about that? Red laser. जो red वाली laser है. Laser pointer जो किस बटन से ऊपर वाले से उधर भी पॉइंट आउट ठीक है ठीक In the name of Allah, the most beneficent, the most merciful. Our Prophet Muhammad, peace be upon him, said, and I quote, "There are two blessings which many people waste, health and free time," unquote. Today, I'm going to present my study on expression of PD-L1 in non-small cell lung carcinoma. This shall be the sequence of my presentation. Lung cancer is one of the leading causes of death worldwide. It is broadly classified into small cell carcinoma and non-small cell carcinoma. The non-small cell type predominates. The prognosis is usually dismal. PD-L1 is an immune modulator.
It is expressed on the surface of antigen-presenting cells and various connective tissue elements, while PD-1 is expressed on the surface of cytotoxic T cells. Usually in vivo, the PD-PDL1 interaction dampens the immune response. This prevents the damage to the healthy tissues. Now, what happens that some of the tumor cells also express, rather some of the tumors also express PDL1 on their surface. This PDL1 interacts with the PD1, and in this way they evade the immune attack against them. Immune checkpoint inhibitors. Immune checkpoint inhibitors are actually the monoclonal antibodies. They are either directed against PD1 or PDL1. Their main aim is to inhibit the interaction between these two and enhance the anti-tumor activity of the immune system. Here in this figure, this is an antigen-presenting cell. This is presenting the epitope to the CD8 positive T cell. Once it gets activated, it attacks the antigen, which in this case is a tumor cell, and destroys it. Here again, this is the tumor cell, which is recognized during the immune surveillance. The cytotoxic T cells will usually destroy it, but those cancers which express PDL1 on their surface, they evade it because the PD-PDL1 interaction inhibits the effector function. Now the study. My objective was to determine the immunohistochemical expression of PDL1 in non-small cell lung carcinoma in our population at a tertiary care hospital. The rationale of my study was to explore the expression of PDL1 in non-small cell lung carcinoma so as to select the candidates for the immunotherapy which are likely to get benefit out of it. The sample size calculated as per WHO sample size calculator was 145, keeping the confidence interval at 8%. These are my study parameters. After approval by Institutional Review Board, all the newly diagnosed cases of non-small cell lung carcinoma were subject to immunohistochemistry for PDL1 using the clone 28-8. It is pertinent to mention here that apart from 28-8, there are few other clones which are FDA approved. And against the positivity of each of these clones, a separate drug is used. PDL1 was interpreted using the guidelines from International Association for Study of Lung Cancer Atlas. All the cases showing positivity of more than 1% were graded according to the guidelines provided for 28-8. All the tumor cells expressing the membranous positivity of any intensity and whether partial or complete were interpreted positive. In this figure, positivity is membranous and strong, while in this figure, it is weak. So both are actually interpreted positive. The figure A is interpreted high positive, while B comes under the category of low to intermediate. Data was analyzed using SPSS version 25. Post-stratification chi-square test was applied, and p-value of less than 0.05 was considered significant. Now the results. Out of 145 cases, 114 were male and the remaining were female. In our study, we observed squamous cell carcinoma to be the predominant histological type. And this is in accordance with the data from AFIP monograph for the last decade. Expression of PDL1 was seen only in 35 cases, which makes it 24.13%. The frequency of expression of PDL1 was more amongst moderately differentiated tumors. and the frequency of PD-L1 expression was more amongst adenocarcinomas as compared to squamous cell carcinomas. Now the discussion. Similar to our study, a study conducted at China revealed positivity of 38.5%, while a study at Germany depicted positivity of 32.8%. Similar to our study by Zhang et al. Also reported higher expression of PD-L1 in high-grade tumors as compared to low-grade tumors. As we observed, higher frequency of PD-L1 expression amongst adenocarcinoma. Contrary to that, Shield et al. Reported equal expression of PD-L1 in both the histological type, while conversely, Lin et al. Reported higher expression of PD-L1 in squamous cell carcinoma cases as compared to adenocarcinoma. To conclude, I would say that although PD-L1 expression is not substantial, yet cannot be overlooked, keeping in view the therapeutic benefits to the patients. There is no significant difference in expression of PD-L1 amongst both the histological types. Our recommendations are that PD-L1 should be tested in non-small cell lung carcinoma biopsies in the better interest of the patients. And it would be optimal that another study is conducted on large-scale population to authenticate the results. I thank you all.
Thank you, Dr. Umair. Our next presenter is Dr. Madiha Bilal Qureshi.
Assalamu alaikum, everyone. Today, the topic of my presentation is clinicopathologic characteristics of ossifying fibromyxoid tumor. So, ossifying fibromyxoid tumor is a rare mesenchymal tumor with uncertain differentiation with a median age of 50 years. Male to female ratio is 2:1 and it may involve any part of the body. Common sites are extremities and it has PHF1 gene rearrangement. It usually occurs as a painless, slow-growing subcutaneous mass. As you can see, here's a skin-covered nodular tissue and a nodular tumor which on cut surface has gray-white appearance. Now here you can appreciate that there are two nodules and there is a capsule, and at the periphery there is this white area which is bone formation. Radiology typically shows a circumscribed lobulated mass which may have a peripheral calcification or intralesional mineralization. Histologically, it is a lobulated, encapsulated tumor with an incomplete peripheral shell of bone, and it shows cords and trabeculae of cells in a hyalinized to myxoid background. It is classified into typical, atypical, and malignant variants depending on the cellularity, nuclear grade, and mitotic count. Anything which has low cellularity, low nuclear grade with one mitosis will be typical. Anything with high cellularity or high nuclear grade with greater than 2 mitoses will be malignant. However, anything between the two will be atypical. For example, if we have a tumor with low cellularity and 2 mitoses, that would be atypical. Objective of my study was to elaborate the distinct clinicopathologic spectrum of OFMT. Now, all the diagnosed cases of OFMT between 2013 to 2022 were searched, histologic features were assessed, and follow-up was taken. Results. Out of the 19 cases, there were 13 males and 6 female, and a male-to-female ratio of 2:1, which is very comparable to the studies in the literature. The age range was 22 to 67 with a median of 37, which is lower than what is reported in the literature. Literature says it is 50. And tumor size range was 1.6 to 17 centimeter with a median of 6, which is slight more than what is reported in literature, which says 4 to 5 centimeters. Laterality was right in 8 cases, left in 8, and midline in 1. Most common site was buttock, followed by thigh and foot. And there were some rare sites like parietal area and buccal mucosa. So the most common area was lower limb. Most common tumor location was subcutaneous. Tumor growth pattern most common was circumscribed, and nodularity, multinodularity was seen in most of the cases. Now the results of histologic type. We had 12 cases of typical OFMT, 8 were ossifying types, and 4 were non-ossifying variants. All of them had low mitotic count, low to moderate cellularity, mild atypia without necrosis. There were 3 cases of atypical OFMT, which had 2 mitoses, low to moderate cellularity with mild atypia and no necrosis. And there were 4 malignant cases, which had 11 to 19 mitosis and necrosis with moderate to mild cellularity and atypia. Now, satellite nodules is basically presence of nodules of tumor in adjacent tissue. Here you can appreciate, seen in 14 cases. Skin ulceration was present in 2 cases. Architecture was trabecular cords in all cases. Additionally, nesting was present in 14 cases. Fascicular pattern was seen in 10 cases, and microcystic appearance was seen in 7 cases. Cells were round to ovoid in shape in all the cases. Spindling was seen in 14 cases, and multinucleated cells were seen in 1 case. Stroma was collagenous pink to hyalinized in all the cases, and myxoid stroma was present in 17 cases. Bone formation was present in 15 cases, and unlike literature, we had more bone formation within the tumor rather than at periphery of the tumor. And we had within tumor cases of 14, and at periphery, 6 cases had bone formation like this. And here you can see there are nodules of the tumor and intervening bone. Now the bone type, reactive woven bone was present in 12 cases, and mature lamellar to sclerotic in 5 cases. Cartilage formation was also seen in 1 case. Now immunohistochemically, all the cases were positive for CD56. S100 positivity was seen in 63% cases, and ASMA was positive in 16% cases. We didn't have any positive case for Desmin or MUC4, which are seen in some cases of OFMT. So this is a typical OFMT, CD56 positivity, and S100 positivity. Now follow-up was available in 13 cases, and the duration was 2 to 8 years. Out of these typical cases, 7 were treated with surgical excision, and there was no recurrence or mets. However, 1 case was of a 37 male with hand swelling and typical features, but this patient developed recurrence within a year. There was re-excision with adjuvant chemoradiation, but tumor developed metastasis, and it was after 2 years, and the site was lung, leading to death of the patient. Then there was another patient who was a 56 male with swelling in the foot. Typical features, had recurrence within a year, and had re-excision with adjuvant radiation. Still now, the patient is metastasis free. Now, out of the atypical cases, there were 2 cases which did not develop any recurrence or mets. One of the case, which was in the parietal area, which is an unusual area, developed recurrence after 5 years, and the biopsy and treatment is still awaited. Unfortunately, we did not have a good follow-up of malignant cases. There was follow-up was only 1 case, and that case did not had any recurrence or metastasis. So conclusion and the take-home message is, OFMT is a rare mesenchymal tumor with distinct histologic features, but it may show a range of morphologic spectrum. It should be considered in differential diagnosis of low to intermediate grade bone-forming tumors of limbs. It occurs at a relatively younger age in our population with a relatively larger size on clinical presentation. It has unpredictable potential for local recurrence and mets, irrespective of the aggressiveness of the histologic features, which we saw here that there was a case of a typical OFMT and the patient died. So close follow-up of the patients is recommended. Thank you.
Thank you, Dr. Madiha. Next presenter is Dr. Saira Javed.
Bismillahirrahmanirrahim. I'm Dr. Saira Javed, resident at Histopathology Department at Chuptai Institute of Pathology. I'm going to present my study that is about the evaluation of immunohistochemical expression of mismatch repair proteins in prostatic adenocarcinoma. Prostate cancer is the second most common malignancy in men worldwide. Even in Pakistan, according to Punjab Cancer Registry report of 2018, it is the second most prevalent tumor in men. Incidence and mortality rate of prostate cancer strongly correlate with advanced age. Initially, the entire focus was on clinico-pathological parameters that include PSA level, Gleason score, grade group, perineural invasion, and tumor load. However, recently with marked advancement in the field of molecular genetics and targeted therapy, these clinico-pathological factors are now considered suboptimal therapeutically. Hence, there is a great need to understand the biological behavior of disease by recognizing the molecular markers to predict the aggressive nature of tumor and for targeted therapy. A very few studies have been published on prostatic adenocarcinoma to analyze the role of mismatch repair proteins or its deficiency and its association with Lynch syndrome. A few words about the history of Lynch syndrome. 100 years ago, Allred Warden at University of Michigan described a family G who had a predisposition for gastrointestinal as well as gynecological cancers. Later on, Henry Lynch in 1961 published data from two family pedigrees who also had clustering of similar cancer. In the mid-80s, this syndrome was named as Lynch syndrome. The role of MMR protein in prostatic adenocarcinoma is a matter of controversy. Hence, the study was planned to look into the expression of 4 mismatch repair proteins in prostatic adenocarcinoma in our population. A cross-sectional descriptive study was performed on 74 cases of acinar prostatic adenocarcinoma, while ductal adenocarcinoma was excluded from the study because of low frequency and lack of association with mismatch repair proteins, according to literature. Study was carried out for a period of 6 months between December 2021 and May 2022 at Chuptai Institute of Pathology. Data was analyzed by using the SPSS version 22 and immunohistochemical analysis and interpretation of 4 antibodies were performed. This is how we interpret our result. A nuclear loss of any of antibody was considered as negative, while retained expression of any antibody was considered positive. This is the scheme according to which we analyze our results. When there was intact antibody, it was considered as sporadic tumor or non-Lynch syndrome associated tumor. However, concurrent loss of MSH2 and MSH6 was considered a candidate for genetic counseling for Lynch syndrome. When there was concurrent loss of MLH1 and PMS2, it was considered a candidate for BRAF mutation. Absence of BRAF mutation with absence of hypermethylation of MLH1 was also considered a candidate for genetic counseling for Lynch syndrome. Moving to the results, the age range in my study was from 50 to 98 years with a mean age of 68 years. Majority of cases were received through TERP. The isolated loss of mismatch repair proteins in over out of 74 cases in my study showed 9 cases loss of MSH2 and 9 cases for PMS2. While there was loss of MSH6 in 2 cases, however, none of the cases show negativity for MLH1. The concurrent loss of MSH2 and MSH6 was seen only in 1 case. We then correlated the loss of MMR proteins in relation to age, Gleason score, grade group, perineural invasion, and tumor load. And we found that majority of patients in which there was isolated loss for MMR protein was above the age of 50 years with Gleason score of 10, grade group 5, and tumor load above 50. Moving to the discussion, in recent years, prostatic carcinomas with concurrent loss of pair MMR protein are considered to link with Lynch syndrome. However, isolated loss are considered to be of sporadic origin. Identifying the patient with Lynch syndrome is essential for screening and early detection and surveillance for other Lynch-associated tumors. Worldwide, the detection of MMR protein is performed routinely in well-known cases like colorectal carcinomas and endometrioid adenocarcinoma. However, in Pakistan, there is no routine evaluation for MMR protein in well-known cancers or even in prostatic cancer. To the best of our knowledge, no study has analyzed the link between MMR protein deficiency and prostatic adenocarcinoma in Pakistan. In current study, we evaluated the IHC expression and correlated with clinical pathological parameters. We found that there was association between incidence of prostatic adenocarcinoma and advanced age, pointing it for its sporadic origin. Majority of cases in which MMR deficiency was observed, they belong to grade group 5 and tumor load more than 50. This is one of my reference study that was done by Guides at University of Johns Hopkins, in which he also correlated the loss of mismatch repair proteins with advanced age, higher grade group, and higher Gleason score. However, one of these study by Gonzalez et al. In 2020, he found no correlation between aggressive nature of tumor and loss of mismatch repair proteins. Present study revealed a low frequency for isolated loss of mismatch repair proteins, linking to sporadic origin. These low frequencies match with the result of studies conducted in the past, where deficiency of MMR protein was noted in a very few cases. But a concurrent loss of MSH2 and MSH6 that was seen in our study reflects to an association with Lynch syndrome. That single patient was the age of 52 years and was comparatively younger with higher grade group and more than 50% of tumor load. Knowing the pathogenesis of any disease is of great significance in predicting the prognosis. Studies have revealed poor prognosis for sporadic prostatic adenocarcinoma, while favorable outcomes have been reported with patients having MMR deficiency. It is because MMR deficient tumors have more sensitivity to anti-PD-1 and PD-L1, suggesting for its predictive nature. In case of colorectal carcinoma, the role of PD-1 and PD-L1 is well known. However, in case of prostate cancer, the role of anti-PD-1 and PD-L1 is yet to be established, primarily because of the scarcity of data. Now, I would like to conclude my study that my study revealed a low frequency of IHC expression of mismatch repair proteins, especially the concurrent loss of mismatch repair proteins. However, association of prostatic adenocarcinoma is noted with loss of MMR proteins. Thus, present study does not warrant for reflex testing or screening in every case because of low frequency, probably suggestive of sporadic nature. I would like to acknowledge my co-authors. Thank you.
Thank you, Dr. Saira. Next, we have Dr. Ikra Mahmood.
Bismillahirrahmanirrahim. Assalamu alaikum and good afternoon. It's a great pleasure to be here. The topic of our study was pathological outcome of papillary breast lesions reported on core biopsies experienced at Shifa International Hospital, Islamabad. Papillary breast lesions are quite rare, comprising of diverse group of lesions ranging from benign to malignant. Clinical and radiological findings cannot ascertain their nature in isolation. They are commonly targeted via corneal biopsies, which has its own diagnostic implications. Papillary neoplasms are composed predominantly of papillae, which are comprising of fibrovascular core lined by epithelium, with or without myopathic cell layer, depending upon the nature of the papillary lesion. Recognition of myopathic cell layer is crucial, for which immunohistochemistry is very essential. Intraductal papillomas harboring ADH or DCIS are difficult to distinguish on corneal biopsies, as the difference between them is quantitative, that is 3 millimeters. There has been gradual evolution in the classification of papillary breast lesions published in WHO. In the first two editions, published in 1968 and 81 respectively, there were two categories, benign papillomas and papillary carcinomas. The third edition, the terminology of intraductal papillary neoplasm was introduced, which included 5 entities, intraductal and atypical papilloma, intraductal papillary carcinoma, intracystic papillary, and invasive papillary carcinoma. In fourth edition, published in 2012, the terminology of intraductal papillary lesion was introduced, and there were introduction of two new terminologies, encapsulated papillary and solid papillary carcinomas. The current edition, which is the fifth one, published in 2019, the terminology of papillary breast neoplasm was introduced, and it was more or less same to the fourth edition. The only difference was the intraductal papillary carcinoma was renamed as papillary DCIS. The objective of our study was to record the spectrum of papillary lesions diagnosed on core biopsies and compare the initial diagnosis with the final ones on excision. It was a retrospective observational study carried out after the approval of IRB of Shifa International Hospital, spanning from January 2010 to December 2021, that is total of 11 years. Electronically maintained data was retrieved and analyzed, and parameters like age, source, laterality, clinical presentation, and radiological findings were entered. After thorough literature review, we were able to define our upgradation criteria as follows. All those lesions not diagnosed on core biopsy to be definitely malignant, and subsequently on excision confirmed as in situ or invasive malignancy will be considered upgraded. Now I'll discuss the results. Mean age of our study population was 55.4 years, with age ranging from 21 to 100 years, and all of our patients were female. In total span of 11 years, we diagnosed 60 core biopsies as papillary lesions. We receive a major share from outside the Shifa, but there's predominance of specimen from within the Shifa. Majority of the patients present with the complaints of nipple discharge and lump. On radiology, these were category 4 lesions. The point to be noted here is that in 62% of cases, we do not know any radiological category. We lack the clinical information over here. As the classification of papillary breast lesions have evolved over the year, so does our diagnostic terminology has evolved over a decade. It is reflected by the different diagnostic terminologies used in the diagnosis of the core biopsies by different consultants in different time of the year. The most important thing to be noted over here is the papillary breast lesions, which were completely benign, were committed as intraductal papilloma or benign papillary neoplasms in the diagnosis, whereas the lesions which showed atypia or any sort of suspicion of malignancy were referred according to the classification applicable at that time and diagnosed by the different consultants. There was an elaborated comment in the end which enlisted the differential diagnosis in the order of their priority, and in majority of the cases, it was suggested that the diagnosis will be confirmed on excision. Here you can see the examples of those 60 cases. So for the purpose of a study, we have broadly classified our diagnostic terminologies into 4 broad groups. There were 25 papillomas, 5 benign papillary lesions, 14 atypical papillary lesions, and 16 papillary neoplasms favoring carcinomas. Out of these 60 cases, we received excision of 29 specimens only. This was a major limitation of our study. All 5 papillomas diagnosed on core were confirmed on excision. 3 benign papillary lesions remained benign. One was intraductal papilloma, was papilloma with papilloma with ADH, and third was adenomyopithelioma. 8 carcinoma were confirmed on excision. Out of these 4 groups, only atypical papillary lesions fits our upgradation criteria. 2 were in situ malignancies and 4 were invasive, as shown in this flow chart. Among the 8 carcinomas confirmed on excision, 2 were solid papillary, 1 was papillary DCIS, 2 were conventionally mammary, and 3 were encapsulated papillary carcinomas. The upgrade rate of our study was 20.6%. Chi-square tests were applied, and p-value was calculated, and both of them were statistically significant. This table compares the results with different studies carried in different parts of the world and different times of the year. In studies carried out in 2011 in USA, 2016 in Korea, 2013 in Thailand, there was significant upgradation rate of benign papillomas. The most reassuring thing in our study was that there was no papilloma which was upgraded or carcinoma which was downgraded. After retrospectively analyzing our atypical papillary lesion, we were able to enlist the cause of upgradation as follows. Scanty and fragmented biopsy material. This was mainly due to the variability in the thickness of the core needle biopsies used. Literature recommends the use of 14 to 16 gauge needle. In our setup, we use 16 gauge needle. But since we receive our major share from outside the Shifa, there is variability in the thickness of the core needle biopsies. The third cause of upgradation was sampling error, 4th was infarction, and another important limitation was inconclusive IHC, which will be shown in the coming figures. Now I'll discuss the few of our upgraded cases. Case number 1 of a 2-year-old female. The core biopsy showed the papillary lesion, showing conventional papillary area along with the apocrine change, showing other areas with apocrine change. IHC was applied. CK5-6 showed heterogeneous expression, positivity in certain areas, negativity in other. Same was the case with ER, which showed heterogeneous expression. Atypical papillary lesion was diagnosed. Comment was given to excise the lesion. We received the excision having following morphology. Left-hand side of the figure shows conventional papilloma, whereas the right-hand side showed papilloma with apocrine morphology. On high-power view of the apocrine areas, there were certain cells showing cytological monotony, and this area was mounting to more than 3 millimeter. Hence, this case was diagnosed as intraductal papilloma with apocrine DCIS. Another case is of a 41-year-old female. We received a core biopsy showing a tubulopapillary architecture. If we notice it, there is accumulation of luminal eosinophilic secretion. Again, IHC was applied. ER showed heterogeneous expression. ER was diffuse positive in certain areas, negative in others. CK5-6 and P63 were negative. Atypical papillary lesion was diagnosed and comment was given to excise the lesion. So we received the excision of this specimen. The excision biopsy revealed tubulopapillary architecture. The tubular areas showed the luminal accumulation of eosinophilic secretions. These secretions were resistant to washout on DPAS, and the tumor was strongly positive for S100 on immunohistochemistry. Hence, it was diagnosed as secretory carcinoma, which is well known to harbor the tubulopapillary architecture. So it is being hoped that over the years, better characterization of papillary lesions will help in adoption of uniform diagnostic terminologies, particularly in the case of core needle biopsies. Development of more specific and sensitive immunohistochemical markers, and the current notion of usage of 2 or more myopathial cell markers will help in resolving much of the diagnostic confusion. Once the papilloma is confirmed, it does not need excision, provided there is good clinical, radiological, and pathological correlation. Our study concludes that core biopsy in conjunction with IHC provides an accurate provisional diagnosis in most cases. It is very important to be stringent in diagnosis of benign papillomas. But excision will always remain the conclusive method for definite categorization of atypical papillary lesions. These are the references I have used in my study. Thank you very much for your attention and patient listening. Any questions would be appreciated. Thank you.
Thank you, Dr. Ikra. Our next presenter is Dr. Mohammad Anik.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Mohammad Anik, the resident of MPhil Pathology, Liaquat University of Medical Health Science, Jamshoro. My study for the PAP conference is the incidental finding of the retained product of conception in the hysterectomy specimen with a clinical indication of AUB and DUB. Introduction. The abnormal uterine bleeding, dysfunctional uterine bleeding, DUB, is an abnormal gynecological complaint representing 1/3 of the ambulatory brain visit to the gynecologist and representing over 70% of all premenopausal and postmenopausal gynecological consultation. A research based on the menstrual problem epidemiology in the developing nature has shown that the AUB or DUB prevalence was about 5 to 15% in the developing countries, including Pakistan. The aims and objectives: the International Federation of Gynecologic and Obstetrics proposed a novel classification of AUB, that is plum-coin, the polyp, adenomyosis, leiomyoma, malignancy, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, not otherwise classified. Our aim of the study to signify the importance of ruling out the possibility of abortion and the retained product of conception as an important cause of AUB before hysterectomy procedure. Material methods, study setting. This study was conducted in the Department of Pathology, Liaquat University of Medical Health Science, Jamshoro. Study setting, a cross-sectional study. Sampling methods, non-probability, convenience approach. Study duration was the 5 years from January 2017 to May 2022. Inclusion criteria, hysterectomy specimen with the incidental found retained product of conception. Exclusion criteria, hysterectomies with a diagnosis of polyp, adenomyosis, leiomyoma, malignancy, coagulopathy, ovulatory dysfunction, and autolytic specimen were excluded from the study. Sample size, total 6,821 cases of hysterectomy were analyzed out of which 50 cases of the hysterectomy specimen was selected according to our inclusion criteria. Statistical analysis. The data was analyzed in the SPSS software version 26. Frequency, percentage, mean, and a standard deviation was calculated using a descriptive statistical test. Age were reported quantitatively as a mean and a standard deviation, while the histopathological results were expressed as quality as frequency and percentage results. The age range was 25 to 50 years, 55 years of age with a mean age of the 37 plus minus 64. Table 1 shows the hysterectomy specimen with 12 cases of the total abdominal hysterectomies, 2 cases from the total abdominal hysterectomy with the right salpingo-oophorectomies, 2 cases from the total abdominal hysterectomy for the left salpingo-oophorectomies, 34 cases of the total abdominal hysterectomy with bilateral salpingo-oophorectomy. Table 2 shows the histopathological finding in the endomyometrum, in which 36 cases shows the RPOCs only, 8 cases show the RPOCs with adenomyosis, 4 cases show the RPOCs with leiomyomata, and 2 cases shows the both RPOCs with both adenomyosis and leiomyoma. Table 3 shows the histopathological findings in ovaries and fallopian tube, in which 12 cases shows the hemorrhagic corpus luteum, 4 cases shows the follicular cyst, and 22 cases shows the insignificant findings, like the corpus albicans, corpus luteum, small cystic follicles, and corpus luteal cyst. For the fallopian tube, 2 cases for the paratubal cyst, 1 each cases of the hydrosalpinx febrile cyst, chronic follicular salpingitis, tuberculosis, and 32 cases for the insignificant findings. Discussion. Our study mean age was for the hysterectomy was reported 37. These two study reported the mean age for 45 and 46 years. Comments for this indicates that in our region, the hysterectomy surgery is being carried out at a considerable young age, which is quite alarming and required itself great concentration. In our study, in current study, we observe only RPOCs cases in 72%, and the RPOCs with adenomyosis in the 16% of the cases, 8% cases shows the leiomyomata, and the 4% of the cases show both adenomyosis, RPOCs with adenomyosis and leiomyomata. These 3 studies reported the adenomyosis and leiomyoma in their uterine specimen findings, but neither of these studies found any incidental found of RPOCs in their sample. Comments. Thus, given the strong results of RPOCs in our study, we cannot overlook the possibilities of RPOCs may have been the main factor contributing the patient bleeding, for which a proper diagnostic approach is needed before hysterectomy surgeries. In our study, we found that the ovaries were unnecessarily excised despite being of a small size and insufficient findings. This similar study performed their study, and the bilateral oophorectomies, especially in the reproductive age, is linked with the accelerated age, neurological disease like dementia, depression, and the other chronic conditions like diabetes, hypertension, and stroke. Conclusion. Although we are unable to find any evidence of retained product of conception in hysterectomy specimen in the literature, but current finding shows that the possibility of abortion should always be excluded through the serum beta HCG level before opting hysterectomy procedures. It's the dilemma of the developing countries that a proper diagnostic approach, that is detailed history, laboratory tests like the pregnancy test, clinical examination, are not being performed before surgical procedures. These are the references. Thank you.
Thank you, Dr. Anik. Our next presenter is Dr. Syed Muhammad Ishaq.
Bismillahirrahmanirrahim. I am very thankful to the organizing committee to give me an opportunity to present my small part of the PhD research. This project is made in the Kesweb University of Balochistan with the collaboration of Bolan Medical Complex and Civil Sandeman Provincial Hospital, Quetta. Esophagus is a hollow muscular tube which connects the lower end of the pharynx with the upper end of the stomach. It is composed of anatomically three parts. Upper portion is the skeletal muscle, and middle one combination of the skeletal as well as the smooth muscle, while lower part is composed mainly of the smooth muscle. Histologically, it is mainly lined by stratified squamous epithelium, while the lower 1.5 to 0.5 centimeter is lined by the columnar epithelium. Esophageal malignancy is a very high virulence malignancy which have a very poor prognosis, and 5-year survival rate in higher setup is hardly 15 to 25%. In our setup, maybe less than 10% of the cases. Approximately half of the cases of the esophageal cancer were presented at the distant metastasis when they are at their first presentation. Worldwide, esophageal cancer is accounting more than 4 lakh death annually with this malignancy in South and East Africa and Asia, counting highest rates more than 100 patients per 1 lakh population. There is Asian cancer belt which extends from the North Iran through the Central Asian Republic of North Central China, which may including some part of our country as well as Afghanistan as well. Esophageal cancer is the fourth commonly diagnosed malignancy and the fourth leading cause of its related death in China, with the estimated rate of 2,59,000 cases and 2,11,000 cases ratio in 2008. In India, it is represents the third and fourth leading cause of the male and female gender. Globally, Quetta region of the Balochistan is counting the highest incidence regions for this esophageal malignancy when compared to the Karachi region, which is counted as the middle moderate incidence rate. Esophageal cancer is the 7th and 6th most common malignancy in male and female gender in Karachi, while it is counted to be the 3rd most common malignant neoplasm in Quetta regions. As environmental factor may be included in tobacco smoking, drinking alcohol, and other dietary factors thought to be associated and play a main significant role in the esophageal malignancy. Low intake of raw vegetable, fresh fruits, and deficiencies of the vitamins which may have protective effect in antioxidant. Intake of hot beverages may lead to the thermal injury, which may lead to tears and ulcer formation in the mucosa and may lead to malignant formations. Other risk factor in the form of the spicy food, red meats, poor oral hygiene, lifestyle, socio-economic status, and the level of the education. Medical factors are there in the form of genetics, drugs, and family history of the disease. This cross-sectional study is carried out in the Department of Pathology as well as Gastroenterology in Bolan Medical Complex, Sandevan Provincial Hospital, Quetta, from January 2019 to 13 June 2020. total cases of 231 were selected in surgical pathology relevant data, and the other separate proforma were noted in separate proforma. All slides were studied by low power, high power, and followed by 2 histopathologists. Inclusion were the patient presented with a dysphagia, retroexternal burning pain, vomiting, iron deficiency anemia, and clinically suspected as a esophageal malignancy. While in exclusion, those presentations were not included as an esophageal lesion. Poorly fixed, inadequate tissue were also included. Descriptive statistics were used by the percentage and Excel data. The degree of the salty and spicy food, hard beverages, and fresh fruits, milk, meat, tobacco, and other were categorized as mild, more to high. A few mini and moderate were modified as 1+, 2+, 3+. Our observation, our results showed that majority of the cases are from the malignant lesions, and the frequency of the esophageal carcinoma in our study was 65% cases, which is followed by chronic esophagitis, which is up to 20% of the cases. Barrett esophagus, hyperplasia, and high-grade dysplasia was 4% each. Other variant of the esophagitis will be noted in 2.5%, while benign lesion were noted in only 2% of the cases. This table shows the above description as you observe. And the alcohol, which is counted as a 1+ up and on use in a week. Drugs in the form of non-steroidal proton pump inhibitor, H2 receptor antagonist, and others. 1+ occasional type may taken daily. 2 types, 2+ may 2 types are daily. 3 or more types may taken daily. Quid may be in the form of tobacco by oral or by nose. 1+ 5 times a day. 2+ 6 to 10 times a day, and 3+ more than 15 times a day. Smoking cigarette 1+ maybe in the form of the 5 to 8 cigarettes per day, where 2+ 10 to 15, and 3+ more than 20 cigarettes per day. Salted spices food 1+ taken 2 times a week, 2+ 2 times a week, and 3+ more than 2 times a day. While tea and hard beverages up to 700 ml counted as a 1+, 2+ is the up to 1200, and 3+ 1 to 700 per ml. This table shows that the alcohol consumption were negative in 75% of the cases, while drug positivity were observed in 62% of the cases. Quid taken Naswar and the other one in the form of the 40% of the cases, while smoking were in 20% of the cases. Salted food were positive in 52% of the cases. Spicy food may be presented in the 52% of the cases. Hot tea and beverages and other beverages may positive in the 82% of the cases. Fresh food 1+ taken 2 times a week, 2+ 3 to 4 times a week, 3+ more than 5 times a week. Fish 1+ 1 up and on were occasionally intake in a week, 2+ 2 times a day, and 3+ 5 times a day. Milks, beef, chicken, mutton, and vegetable 1+ may counted in once in a week, and 2+ every third day, and 3+ more than 3 times a day. This is the this table shows that the fresh fruit intake were occasional intake were 68% positivity. Fish were 65% negativity. Milk intake were occasional intake in 57% of the cases. Beef intake were 52% of the cases, while the chicken intake were also 52% of the cases. Mutton were 50% negativity. Vegetable intake were 62% of the cases. While discussion frequency of the esophageal carcinoma were noted very high, followed by the chronic esophagitis. These are comparable with other Pakistani studies who reported that Quetta region is the high incidence of the esophageal carcinoma and considered a third commonest neoplasm. Use of spicy and salted food had a 53% positivity. These are comparable with other studies who reported that major risk factor or excess intake of the processed spicy and salted food have great positivity and significant correlation with esophageal malignancies. Now, use of liquids, 45% positivity may be orally taken or by nose, which may badly affect the oral hygiene, cigarette smoking is 21% positivity, alcohol consumption were very low, maybe due to the religious reasons, non-availability of beer easily or cultural habits. 75% maybe had a negative, only 25% may had occasional intake of the alcohol, which may shows no significant correlation with esophageal carcinomas. Our result also in agreement with the studies who showed that smoking, chewing pan, eating naswar, and inhaling snuffs may consider as a low risk factor in esophageal cancers. They claim that the smoker naswars taken may increase risk of the lesion 2 and 3% time higher than the non-user. Other study may observe that tobacco smoking may be in the form of chewing, nas, or pour may lead to poor oral hygiene, which may consider as a major risk factor. These further study may show that low risk factor areas in tobacco smoking were considered as a major risk factor, whereas in high risk areas where the etiology were not much clear, and there is no significant correlations. Iranian and US studies may reported that in high prevalence area, esophageal carcinoma is more common in Iran and China, where smoking and alcohol were considered as a minor risk factors. The other studies also showed that 90% of the cases of the esophageal cancer in West were associated with smoking and alcohol user, whereas in the high risk areas, Asian cancer belt and Iran, there is no significant role to consider it as a major risk factor. Heart beverages, green tea, and bread with the heart soups may have 82% positivity, may lead to thermal injury, esophageal to the mucosa, and may lead to chronic inflammatory process, lead to the non-healing ulcer, dysphagia, carcinoma in situ, and esophageal squamous cell carcinoma. Similar finding may be observed by the group of researchers who claim that the heart beverages in high quantity may associate with high risk factor of the esophageal cancers. Ludhiana, Punjab study showed that heart beverages, malnourished, and low socioeconomic status may lead to the major risk factor for esophageal carcinoma. University of Georgia may reported that tea, green, black, or cholangi may contain active component of the polyphenol, which may lead to esophageal squamous cell carcinoma. Some researchers also reported that high temperature in the tea may be associated with the 1.6-fold increase in the esophageal carcinoma. In Japanese showed strong correlation with the esophageal heart beverages and esophageal squamous cell carcinoma. Our study also showed that 62% cases with affected patients used different types of the drugs, non-steroidal anti-inflammatory proton pump inhibitor H2 receptor, and other may have due to illiteracy. Initially they may take medicine by self-medication, then they by their relative suggestion, and in third step they go to the medical store and general practitioner, and lastly they consult the consult from the physician to opinion, which is made so late. Now these are comparable with the study who reported that different chemicals, drugs, and opium intakes were considered as a risk factor for esophageal cancers. Our result also showed that occasional intake of the fresh fruit milk, which was 68 and 57%, vegetable intake was 50% positivity, whereas fish intake were in 56% of the cases. Similar findings were reported that fruits and vegetable intakes increased to 100 grams per day can decrease the incidence of the esophageal carcinoma in 11% of the cases. Another study reported that low fruits and vegetable consumption have been inverse associated with the esophageal cancer. Brazilian study also showed that consumption of the vegetable, fresh fruit, and juices considered as a protective factors for esophageal malignancy. In this study, meat, either chicken or beef, may be had 52% positivity, whereas the mutation mutton was only 3.5% positivity. Red meat may contain increased amount of the iron, may had pro-oxidation and able to catalyze the peroxidation. Our results are in agreement that reported high consumption of the red meat may affect the the take-home message.
Now because you are much ahead of
Esophageal
time.
cancer has a positive correlation with the various dietary and addictive factors, with the low intake of fruit and vegetable, lack of awareness and socio-economic status, health education to the community and healthcare provider to change the lifestyle and decrease the spread of the lesion. The esophageal cancer may be high in frequency, so patient who presented with esophageal complaint may need the
Dr.
esophageal
Saab, your time
biopsy.
is over, please.
This is the research is product. Thank you. Thank you.
Thank you. Thank you.
Thank you, Dr. Ishaq. Our last presenter for today is Dr. Talat Zehra.
Okay, Bismillahirrahmanirrahim. Assalamu alaikum and a very good afternoon to all of you. I am Dr. Zahra from Jinnah Sindh Medical University, and the topic of today's talk is Dawn of AI-enabled digital pathology, benefits, challenges, and solution. Just a quick overview, as we all know that Pakistan is the 5th most populated country of the world. And if we talk about the cancer cases, according to WHO, every year the new cancer cases in Pakistan is more than 200,000. And this incidence is increasing globally. But if we talk about the pathologists, the number of pathologists is decreasing with every passing year. And this situation is more grave in developing part of the world. So all these issues lead to delayed diagnosis of the patient, which in turn associated with increased morbidity and mortality of precious lives, which could have been saved if diagnosed timely. So at times, the patients, the slides, the block, and the specimen, they have to travel a lot in search of a pathologist. So if we talk about the digital pathology appears as a ray of hope in solving many of these issues. But obviously, there are challenges before full-fledged implementation of digital pathology, which I shall discuss briefly. As far as benefits are concerned, obviously I will not go in too much detail. The benefits of digital pathology is now an open secret, which has been very well revealed by Dr. Anil Purvani. So I will just discuss few things only. Once your data is digitized, you have a digital slide, the quality of slide will remain as it was on the day one. You don't need to go do for restaining or all the other issues which are associated with glass slide. The second most important thing that once you have a digitized data, it's an era of precision medicine and personalized medicine. You can make your own disease model, disease trends, and predict the disease outcome according to your own demographic region, thus opening the doors of precision medicine. Last but not least, obviously, use of artificial intelligence and computational pathology on these data, how I shall discuss in later on. The challenges is a very important issue. Beside all these benefits, the biggest challenge or the biggest barrier for adaptation of digital pathology is that the prices of scanner, either whole slide scanner, digital microscope, or the AI-based software are beyond the budget of many low-resource organizations of the developing country. Similarly, there are regularity barriers, technology glitches. For using this novel technology, you need to have a good IT setup, backup support, and which is technology glitches is a very common issue in our part of the world. Then the last, handling of big data is another issue because the whole slide image, one whole slide image size is in GBs, so it cannot be accommodated in your local computers. You need a big GPU system or cloud system for handling this big data. And last but not least is the user-friendly ergonomics. Pathologists are used to see cases under the microscope for decades. And if all of a sudden you ask them to switch this and seeing the cases on the screen, it will take time. It needs large validation studies before the full-fledged implementation of digital pathology. Okay, not all hopes are lost. Even with financial constraint, with the limited resources, a pathologist can start its digital or computational journey. How? I shall describe a few. If you want to access the whole slide images, you don't have a scanner. There are a number of whole slide image repositories like the Cancer Genomic Atlas and many, which I have discussed already. You can use these slides. They have thousands of whole slide images, which is open source. Similarly, if you want to apply AI and you cannot afford the commercially based AI software, there are a number of AI softwares like QPath, ImageJ, and Cytomine. I myself have worked on the QPath. It's a really pathologist-friendly software. And if you want to use your own data, you cannot afford a scanner, you can simply use the camera-connected microscope, make the digital slides, and with this digital slides, you can annotate it, you can share it for second opinion, and very important, you can use AI on it. How? I shall show you. These are some of my projects which I did with these resource-limited setup, camera-connected microscope, and the digital images. For that, I'm thankful to various AI vendors who gave me their demo versions, and we did the projects on it. This project number 1. We did a pilot study on chorionic villi. As you all know, it's a common repetitive pathology which pathologists come across every day. What we did actually, you can see a digital image at 10x the various size and shapes of chorionic villi. We trained the software to identify all these various size and shapes of chorionic villi, and we trained it to become green after identification. Here you can see. The software was able to identify all the chorionic villi. In another image, you can see the chorionic villi. We did not annotate this image, but keeping the previous knowledge, the software was able to identify these as well, like this. Another image you can see. In this project, we took 60 cases, and the software was able to diagnose 50 chorionic villi completely with full accuracy, so our precision level was 0.83%. The second project, which is very important, which we did on malaria parasite. As we all know that malaria is an endemic disease of developing part of the world. Every year, according to WHO in Pakistan, 500 million people are diagnosed as new cases of malaria. So what we did in this case, this is a peripheral film of malaria parasite at 40x. You can see some nucleated RBCs. We trained the software for various sizes and shapes of malaria parasite present in the red blood cells. We call it as infected RBCs. And after training, the software was able to identify all the MP positive cells. And not only the identify, it can also quantify you. You must be knowing that if a patient is positive, if a single infected RBC is present in the peripheral film, patient needs treatment. And this can be missed by a pathologist in a busy slide. So AI tools are there to decrease your errors actually. In the second project, we did identification of leukemia, blast cells and the leukemia cases. The software was able to identify all the blast cells. Not only identification, it can also do the quantification as well. You can see a slide. Here you can see software was able to identify all the blast cells as large cells and the red cell as the small cells. The next project was on AI on the quantification of ER, PR, and Ki67. AI tools are very helpful in terms of quantification. You can see a Ki67 image at 40x. Ki67 is present, and how the software tells you. The software tells you that how many tumor cells are positive as red, how many are negative, and what is the percentage within no time. The last project was the identification of mitosis and leiomyosarcoma cases. We trained the software, we annotate the images in QPath image software, you can see, and we trained the software for various sizes and shapes of mitosis. With the team of AI scientists, the software was able, we used the software YOLO4, and the software was able to diagnose 0.89% of the mitotic figures. These are the publications, some are local and some are the international, related to digital pathology and AI. These are the references, and the take-home message is that digital pathology and AI tools are not there to replace you. They are there to make your work more easier. Thank you very much.
Thank you, Dr. Talat. Next, we move to the Q&A session. Please put forward your questions for our speakers, if you may have any.
I think we don't have time for questions.
Okay.
So please close it, because we have to go for closing.
Okay. So I would like to call on stage Dr. Naira Khiani to please present shields.
This was really an extremely interesting and mind-illuminating session with sharing of brilliant research ideas from all the speakers. The selection of topic was pretty diverse with wide coverage of different subject areas, and the quality of research papers was definitely very good. And now it seems that research has become a pinnacle priority for all the healthcare practitioners, especially pathologists, because sharing your experience at these forums really makes a lot of difference in practice. Like the conventional methods which were shared for research today, papers related to ossifying fibroma, fibromyxoid tumor, papillary lesions, which are diagnostic dilemmas, definitely have given valuable information to remember, and sharing these practice research papers means that every day the knowledge is advancing for the conventional methods, definitely, but the most interesting area of research that was covered today was based on molecular pathology, which is the mainstay, because molecular medicine is medicine of tomorrow, we know, and that most of our diagnostics are now being addressed at molecular genetic level. So the papers of mismatch repair proteins regarding the prostate as well as endometrial cancer were very, very interesting and useful, and we know that endometrial cancer is still important for the MMR role of proteins as compared to the prostate cancer. But significance of these molecular markers is related to aggressive behavior and targeted therapies. So it makes a world of a difference in highlighting the significance, though the papers were largely based on the most practiced adjunct technique, that is IHC, but recent advances have added panels through the NGS and various other molecular methods. And finally, last but not the least, AI is the future, and we are moving towards digital pathology, which is need of the time. And as very rightly said, that this is a ray of hope with a lot of challenges. But I'm sure facing challenges means more success. So let's be prepared to enter into the era of molecular pathology and digital pathology through AI. That was a great session. Thanks for being with us. All the best.
Thank you, Dr. Talak. Now I would like to call Dr. Naila Kiani to please give shields to our chair and co-chair for the session. Dr. Talat Mirza. Dr. Mariam Musa. And myself. With this, we come to the closing and awards distribution ceremony, which will be moderated by Dr. Asad Jafri and Dr. Zuri Shashfaq.
No, it's closing ceremony, so I will take over. Right? किस चीज़ के लिए? नहीं, अब I think सबने नीचे जाना.
I would request Dr. Asad Jafri to come and take a sheet.
सर आप आइए. प्रोफेसर इकराम उज्जैन साहब हैं यहाँ? हैं? सर आप आइए. डॉक्टर अदनान. अच्छा ये नीचे जाके जरा प्लीज करना हो. जी.
So Zunish is here to collect her sheet.
Okay. All right, so unfortunately time is closing और ये भी हमें हैंड ओवर करना है, तो इसलिए थोड़ा सा रश है. अभी मैं और अदनान साहब अलॉन्ग विद मसूद साहब सारे एग्जिबिटर्स को पर्सनली जाके उनको थैंक किया, उनको शील्ड दी, और बिकॉज विदाउट देयर सपोर्ट without no money, no honey. as they say. so और हमारे बॉस मसूद साहब, उनको हम प्यार से डॉन भी कहते हैं, वो पीछे खड़े, और उनका जितना भी शुक्रिया अदा किया जाए वो कम है. So I think सबसे पहले a huge thank you to all of you who made this event possible, successful, unprecedented in the history of PAP, that close to 1,300 registrants, mashallah, 6 societies running parallel sessions. And I apologize before and I apologize again that our estimates were, crudely flawed. Initially we thought there will be something like 600, and then we thought maybe 800 at the most. But what happened that on spot, day before yesterday and yesterday, about 250 and 300 registrants came on spot. So that's why our planning and the food arrangements, bags, everything got flawed. So please, we sincerely apologize because these things do upset, and we already committed that those who didn't get bags and flash drives, etc., we have already ordered, we have taken their names and tags, and we will deliver them. So this is for sure. So finally, I think we go first to prizes and then life member shields, right? I think all societies, they have delivered their own best oral and poster prizes already at the end of their sessions. So only histopathology is left, which we will do now. That will be followed by the Bukhari Gold Medal, because Bukhari Gold Medal is one and there are 6 societies. So we have 6 nominations, and there will be unfortunately a lottery, and through which we will pick one name and that will be awarded, and the rest will get the certificate that they were nominated for the Bukhari Gold Medal. So that should be as good, and luck also plays a huge role, no doubt, in our day-to-day affairs. So who will be lucky, so qismat ka dhani bhi hona zaruri hai. So I think for posters, I will invite our scientific chair, of the histopathology, Nasir, to please come and Aaja, Nasir. Nasir he is so overwhelmed because he worked so hard all along that, he is a kind of perfectionist, mashallah. So, so I will, and Dr. Naila, please, for the histopathology award. These are the awards, one best oral for the trainees and 3 posters for the trainees. That will be followed by 1 oral and 3 poster awards, which were over and above, not necessarily for trainees, for anyone who were marked by our judges, by courtesy of the Maxim, the DECO, so they always sponsor that, so that's over and above. So over to you, please, about the announcement of G poster ki announcements. Oh, okay, all right.
Assalamu alaikum, everyone. First of all, we'd like to announce the winners for the best poster presentations. So this result was very meticulously carried out by Dr. Mariam Musa and Dr. Shafiq Gill. And the winner for the 3rd best poster presentation goes to Dr. Yumna Ijaz from Liaquat National Hospital. Dr. Yumna Ijaz, are you here? The 2nd prize for the best poster presentation The second prize goes to Dr. Momin Iqbal from Aga Khan University Hospital. Madhya, can you come and collect his prize? नहीं आया वो मैम. And the first prize goes to Dr. Ariba Masood Khan from Pakistan Institute of Medical Sciences. ओरल वाले नाम के पास हैं, उनके पास हैं. ओरल वाले को करना.
पहले मैक्सिमम वालों का कर लें.
जी. The other special prizes for other best poster presentations sponsored by Maxim goes to, the first one goes to Dr. Zishanuddin from Aga Khan University Hospital. The second one goes to Dr. Talat Zehra from Jinsina Medical University. And the third one goes to Dr. Nadia Hassan from Shifa International. Now I'd like to call Dr. Asad Jafri for announcing the winner for the oral presentations.
Okay, so the second prize, which was sponsored by Maxim and was jointly given by HSCP and IAP, goes to Dr. Saima Javed. From sir, actually, abhi scores aaye, we couldn't, from Chuktai, of Chuktai Institute of Pathology. And the first prize goes to Dr. Umair Khan. I think he was from AFIP? Dr. Umair?
AFI.
And this is from PAP, Pakistan Association of Pathologists. Congratulations. All right, lifetime. So, this is more of a ballot kind of thing?
Ballot होगा. All right. इसमें ये है कि तमाम सोसाइटीज से 6 नॉमिनेशंस होंगी हैं और इसके लिए बात को फिर बता दीजिएगा कि नॉमिनेट कौन कौन से हुए हैं. पहले तो हम ऐसा करते हैं कि नहीं, पहले हम वो निकाल लेंगे कि जिसको के देना है और फिर बाकी बताएंगे कौन कौन सी आई हैं और फिर लास्ट में वो वैसे ही बाई एक्सक्लूजन पता चल जाएगा कि किसको मिलने वाला है. तो ताश के पत्तों की तरह से इसमें सर मुबारक हाथ जो है
इसके लिए भी अंदाजे कर लें। आप ही कर लें
नहीं सर, प्रोफेसर सिराज साहब करेंगे। एक इसमें से बस ताकि इसमें से एक जी
मुझसे मिलने आया था आधे घंटे पहले। आग बंद कर, आग बंद कर,
आग मत कर।
1 2 3 4 5 6 आग बंद के निकाल लो, मैं ऐसे करके ये मुझे पता नहीं, आई डोंट नो कौन सा।
अच्छा ये तो वो हो गया जो इनको क्या मिलेगा। अच्छा बाकी नहीं, पहले ये अनाउंस कर दें। ये जरा नासिर आप कर दीजिए मेरे ख्याल में, ताकि एफिलिएशंस वगैरह आपको शायद पता होंगी सब ना।
सब पे लिखा है, मैं देता हूँ।
ठीक है।
ये सब रनर अप हैं सारे।
हाँ। So this nomination's name is Kalsoom, KIBGE, Karachi University, from molecular pathology. Dr. Rifat Bushra, AFIP, microbiology. Pakistan Society of Chemical Pathology, Dr. Zaibun Nisa, AQH. Dr. Khurram Minhas, Histopathology, AQH. Dr. Ali Raza, Pakistan Society for Immunology, Sindh Institute of Urology and Transplantation. So diagnosis of exclusion and M. Umar, AFIP, detection of translocation of multiple myeloma on fish. Dr. M. Umar, AFIP. Molecular, from
ये हेमेटोलॉजी है? नहीं, हेमेटोलॉजी तो ऐसा यूटी से थे।
हाँ, नहीं ये मल्टीपल मालूम हीम से। हाँ,
हेमेटोलॉजी।
सो डॉक्टर M. उमर, AFIP से, उसके बिहाफ पे कोई और?
AFIP से अभी जो हिस्टोपैथोलॉजी में जिनको मिला है, उमैर को बुला लें।
नहीं उनको नहीं।
अच्छा वो चलेगी? अच्छा अच्छा।
आप
नहीं वो तो डालना तो पड़ेगा, आप तस्वीर तो आपकी खींचेंगे।
नहीं
फोटोशॉप कर लें।
देखिए अब ये अब वो नहीं आए तो वो that's unfortunate। अच्छा इंटरेस्टिंग बात यह है कि ये बुखारी साहब एक माशाल्लाह ये तो बड़ा पुराने चले आ रहे हैं, लेकिन अभी मुझे इंडिकेट किया उन्होंने, ये रख लीजिए, कि हमारे पास एक और बुखारी हैं और उनकी तरफ से भी शायद वो है मुलाजिम हुसैन बुखारी। सो आई थिंक द लेगेसी विल कंटिन्यू। अच्छा अब लाइफ मेंबरशिप के लिए ऐसा है कि चूंकि टाइम कम है तो वी हैव 30, तो वो सारे लाइफ मेंबर्स के नाम अनाउंस करेंगे। वो यहाँ से शील्ड्स लेके यहाँ पर एक लाइन बना ले और फिर हमारे साथ ग्रुप फोटो हो जाएगा और बस दैट्स इट। हाँ तो प्लीज अनाउंस करते जाइए आप, यहाँ से अनाउंस कीजिए।
जी जी मैं कर रहा हूँ। ऑलराइट जी। सो द फर्स्ट नेम इज डॉक्टर खुर्रम मिनास फ्रॉम AKU। All right. The second name is Dr. Kuratul and Chundrigar. then followed by Dr. Zishan, then followed by Dr. Sidra Arshad, followed by Dr. Shahid Hasnain Siddiqui, then Dr. Asif Loya, then Dr. Muhammad Mubarak, then Dr. Shahira Shakil, followed by Dr. Rahma Rashid, and then Dr. Farah Kalsoom, followed by Dr. Nadir Hassan, then Dr. Talat Zahra, then Dr. Maria Tasneem Khatak, followed by Dr. Naziz Jafar, Dr. Neelam Mansoor, Dr. Shahida Ashraf, Dr. Muhammad Usman Shams, Dr. Sobia Hassan. The last name was Dr. Neelam Mansoor, Dr. Shahida Ashraf, Dr. Muhammad Usman Shams, and Dr. Sobia Hassan. So you can proceed for the photograph. Sir, somewhere left. Dr. Sabah Humayun, Dr. Sayyid Salman Ali, sorry, the list was long, Dr. Bushra Parveen, Dr. Nasir Uddin, Dr. Fawzia Sheikh, Dr. Nadeem Zafar, Dr. Nasima Iqbal, Dr. Sabah Anjum, and Dr. Safana Sadaf, the life members for PAP. Sabah Humayun, yes, Sabah Humayun.
हाँ, I think what is next बेटा अब टाइम नहीं है।
Next is
जी
ये सिर्फ हिस्टो के
नहीं नहीं सबके हैं भाई, सबके साथ यहाँ दे रहे हैं। लाइफ टाइम मेंबरशिप सबके लिए यहाँ पर।
इसमें नाम नहीं था।
जरा उनसे पूछे ना नाम क्यों नहीं है। अच्छा ये जो है ये भी अनाउंस कर दो ना जी।
All right. There are a couple of other lifetime members for HCSP. Dr. Muhammad Asif, Dr. Khurram Minhas, Dr. Muhammad Usman Tariq, and Dr. Bushra Parveen. Brigadier Dr. Nadeem Zafar, Major Dr. Maria Aslam, and Dr. Saruna Harun, and Dr. Usman Shams and Dr. Sayyid Mahmood Hassan. These are the SCSP life members.
सब आ जाए